देखो
ज्यादा है, बहुत ज्यादा है। हमिंग आ रही वाइट से आ रही है। बहने पता है हाँ समझ गया हाँ वो लैपटॉप माइक पहले ऑडियो तो आया तो मुझसे बोला था कम करेंगे तो इसका बोलने लगा ये सर
ये मेरा नहीं है।
कराओ दिखा रहा है
वो तो खाली है 150 नहीं है।
हाँ मैंने आप ओपन एक मिनट आप इतने मेरे को ओपन कर लीजिए डाउनलोड कर लीजिए
नहीं मैं लाके लाई हूँ।
लेकिन आएंगे आप
मैं मेल कर
एक
दूँगी
बार
आपको। मेल सेंड कर दूँगी तो आप फिर कर देंगे।
कल आप टिकट पे
बुक
कैसे मेरी
वाले
आईडी
उससे
नहीं
लग
चाहिए
जाएगा।
सॉरी
लो। तेरी नूरानी हंसी खिलखिलाती देख हर मौसम शाम दीवानी बन जाए। जहां जाए बस तेरा ही जिक्र हो, तू लखनऊ की ऐसी तहजीब बन जाए। जिस शहर ने हर शायर के दिल का हाल बयां किया है, उसी खूबसूरत नफासत की शहर में आप सभी का हार्दिक स्वागत है। With this welcoming note, let us all tune into the symphony of our hearts and move towards day 2 of the workshop on advances of cytogenetics in clinical applications organized by the Center for Advanced Research, King George's Medical University. I, Shreya Palit of MBBS Batch 2020, am privileged and delighted to steer you along. We shall now honor our delegates with flowers as a token of our reverence. It is my pleasure to welcome our esteemed intellectuals for the day. We have with us Dr. Rajni Gupta, ma'am. We welcome you, ma'am. We have with us Dr. Rashmi Kushwaha, ma'am. It's a privilege to have you, ma'am. Dr. Swasti Sinha, ma'am. We welcome you, ma'am. Dr. Kaushik Mandal, sir. Dr. Kaushik Mandal, sir. We welcome you, sir. Dr. Preeti Agarwal, ma'am. Dr. Inusha Panigrahi, ma'am. We welcome you, ma'am. Dr. Frenny Sheth, ma'am. We welcome you, ma'am. Dr. Sunita Singh, ma'am. It is a privilege to have you, ma'am. Dr. Neetu Nigam, ma'am, our organizing secretary. We are thankful for your guidance, ma'am. On this note, let us now step into the scientific session for the day. Seizing the day with all our might as we awaken from a peaceful night, taking on life's challenges with a confident heart, for each day is a brand new start. I now humbly request our chairpersons for the session, Dr. Rajni Gupta, ma'am, and Dr. Rashmi Kushwaha, ma'am, to kindly grace the dais. Ma'am, please. It is my privilege to introduce to you our honorable chairpersons for the day. We have with us Dr. Rajni Gupta, ma'am, Professor, Department of Anesthesiology, KGMU. Ma'am is also the course director for AHA certified BLS and ACLS courses in our university. Apart from an illustrious teaching experience of 22 years, ma'am has more than 30 publications in various national and international journals to her credit. She has received 8 awards for contribution leading to improvement in patient care, training, and research. Her areas of interest include CPR training, disaster training, trauma courses, critical care courses, and acute post-operative pain management. We are privileged to have you amongst us, ma'am. We also have with us Dr. Rashmi Kushwaha, ma'am, Professor in the Department of Pathology, KGMU. Ma'am has more than 65 publications and 15 presentations to her credit. She has organized the flow cytometry workshop in 2016 and the UP PathCon 2017 as the organizing secretary. Her areas of interest include hematopathology, coagulation disorders, lymphoma, and leukemia. We are grateful to you for gracing the occasion, ma'am. I would now like to hand over the proceedings to our chairpersons for the day. Ma'am, please.
Very good morning to all of you. So starting with today's session, the first lecture is by Dr. Swasti Sinha. She is Assistant Professor in Clinical Hematology in KGMU, Lucknow. She is first diplomat of National Board in Hematology in Clinical Hematology and Hematopathology, Technical Assessor and Inspector in Hematology and Immunohematology for NABL Quality Council of India, credited with setting up tertiary level esoteric testing hematology facilities in large corporate setups, National Faculty Speaker in Hematology and Quality Management, was nominated as International Liaison Counselor for International Clinical Cytometry Society in 2018. Major interest areas include myeloproliferative and myelodysplastic neoplasm, preventive hematology, precision medicine, and cracking challenges and diagnostic difficulty in hematology cases, both benign and malignant. So we welcome Dr. Swasti Sinha.
Thank you, Dr. Rashmi, for such a kind introduction. Good morning, all of you. First of all, I'll like to congratulate Dr. Neetu for putting up such an enriching academic endeavor, Bonanza, and we are here for the day 2. And I'll be speaking on cytogenetics in CML. CML is a chronic myeloid leukemia. ये देखो
अपनी मेल पे करके देखो जरा मैंने भी कर दिया हमको दे रहा
We are privileged to welcome Dr. Nuzhat Hussain ma'am as our honorable speaker for the day. We welcome you, ma'am.
हुआ ना थोड़ा ठीक हो ऐसे ना नहीं करेक्ट नहीं सर करेक्ट अच्छा तो जो हाइलाइटर रहता है ना प्रेजेंट जो आपका लेजर कर अभी हम वो लगाएंगे ना डुप्लीकेट जब तक इनको बुला
Due to some technical errors, we shall have the session with Dr. Kaushik Mandal first. I would like to invite Dr. Rashmi Kushwaha ma'am, our Honorable Chairperson, to kindly introduce our speaker. Ma'am, please.
Good morning. We welcome Dr. Kaushik Mandal. He has clinical expertise in dysmorphology diagnosis, pediatric genetic disorders, genetic counseling, antenatal diagnosis by ultrasonography, amniocentesis, chorionic villus sampling, etc. Laboratory diagnostics skills include Sanger sequencing, MLPA. Ongoing research areas are lymphoma, lysosomal storage disorders, genetic hematological disorders, inherited kidney diseases, genetic neuromuscular disorders, neurocardiofasciocutaneous syndromes, and disorders of growth. He has around 70 publications in index journals, 5 book chapters, and 2 inclusions in London Dysmorphology database. And he is a reviewer of 10 journals, including national and international journal. We welcome you, sir, for the presentation.
हाँ अभी वो
We are privileged to welcome Dr. Nisha ma'am as the speaker for the day. We welcome you, ma'am.
हाँ अभी कनेक्ट नहीं किया ना वो मैं कर लूँगा. हमारे लैपटॉप में प्रॉब्लम है. एक मिनट रुको. अरे वो मुझे मालूम है ना. So I have dedicated one pen drive to virus. So thank you so much for introducing me. I am a pediatrician and has done DM in medical genetics from HGPGI only. So there will be students who might not be very familiar with clinical scenarios, and I won't be talking about cancer or anything. But this is a technique which is being widely used throughout the world. The difficulty is that the probe sets are made by only one country, and probably it will look like that I am trying to make this or glorify one person who is named Schotten. Schotten was the first, and MRC Holland is the company who makes these probes. So like fish probes or various other chemicals, different companies will make. Sometimes we will make it indigenously. This is something we can't make indigenously, and we have to buy it from somewhere. To have an introduction, we all know that chromosomes looks like this, and we look under the microscope to see the chromosomes. And genes are packed inside the chromosome. So one chromosome is a long strand of DNA which has genes. So we need to see these chromosomes and genes, right? So these are the various techniques like karyotype. You look at the number, large deletions or duplications, translocations. That means one chromosome is exchanging material with another chromosome. So this you look by karyotype. Then you have microdeletions, which you cannot look through karyotype, but you need other techniques. They are also called copy number variations, microduplications as well. So you need certain other techniques to look at those. You can't look by karyotyping. Then there are small scale mutations. You know that A is changed to G, C is changed to D. That is called substitution. Few base pair deletions or insertions. You can't look by any of those which you do in microdeletions or through karyotype, right? So you require different techniques. So these are the different techniques. So you can do microarray to look for small deletion duplications. You also look at the genome. Through MLPA, you can scan various parts of the genome, targeted areas. Similarly, for microdeletions, you can use MLPA. It's a technique which is versatile. Then we also have microarray. For small scale mutation, either you have to do Sanger sequencing or you do NGS, right? So NGS, you multiple genes together you do, or Sanger sequencing for targeted exons, you do Sanger sequencing. But you can also use MLPA in certain conditions where you require to look for small scale mutations. So I always give this example. So when we buy a car, if you have a lot of money, you go for a big glamorous car, right? And it is very useful for a long rides. You will not feel stressed riding in a big car, right? But it has exorbitant price and high maintenance cost. This is what microarray is, right? Probably I am not trying to demean any technique, but you need something like a smaller car, which also has good looks, easy to handle, which is affordable, right? For MLPA, for doing one patient, you actually spend around 1000 rupees per sample for chemicals. It is affordable and it is versatile. You use this technique with different probe sets for various. So you need a car like this. So MLP is a technique which is versatile. You can use for chromosome numbers, deletion duplications, intragenic deletions. That means for exonic deletions, you can't use microarray, right? For exonic deletions, you can't use microarray. You can't look at karyotype. You can't use Sanger sequencing for large exonic deletions, right? But this is one where you use MLPA. Even for methylation status, you can use MLPA. It is low price. It is reproducible. There are more than one probe sets for the same region, so that if one probe set comes positive, you can have another probe set to quantify it or be very sure that what you are looking at is correct, right? Then it is easy to handle. You can mix and match various phenotypes, like you have probe sets for ambiguous genitalia, you have probe sets for certain cancers as well. So for looking at the subtelomeres means telomeres, the end of chromosomes, you have one probe sets. You can have for common microdeletions like 7, 15q11 is Angelman Prader-Willi, 22q is velocardiofacial. So these are common microdeletion syndromes which have a very specific phenotype. I will show you some, and you don't need to really do a microarray for that, where you can really find from the face of the child that this baby has these disorders, right? You can just use MLPA. Then you have exonics deletion duplications. We do it for Duchin muscular dystrophy. Duchin muscular dystrophy is a very common neuromuscular disorder. We do it for spinal muscular atrophy, again a very common neuromuscular disorder, where the disorder is due to exonic deletions, large exonic deletions. So you do MLPA for that. We do MLPA for that. It is versatile. So these are the various probe mixes. You can go to the site of the MRC Holland and you can look at what are the different probe sets. For what disorders you want, you can type in the box and find out where there is a probe set. Then you have a mix of 25 probes, you have a mix of 50 probes. So you can, so if you have small number of samples, you can order small number of probes together, probe sets. So to start with, so this baby had a antenatally diagnosed esophageal atresia. You know that esophagus is blocked. So you can do an operation, right? So this is an operable condition, but when the baby is born, the baby had certain dysmorphism, some defects in the limbs, then was small, very small. So they have called a clinical geneticist, which I am, to look at and tell whether there is a syndromic association or not. So this is actually trisomy 18, and you know that karyotype will take time, and trisomy 18 is have a very poor outcome. So for doing an operation on that baby and the outcome is poor, you have to tell the parents. Even if you do the operation, the outcome is poor, but before that you have to confirm it. Karyotype will take 2 weeks. Doing a karyotype will take 2 weeks. So many years back we used to do fish, right? In fish, you see for 318 and that must be a control probe for 21 or something. So and you tell that this is trisomy 18 and the outcome is poor, they might be having associated cardiac disorders. We need to get an echo done to find out. Sometimes antenatally it's also detected. But nowadays we do MLPA. Fish is almost abolished from our lab because fish is costly, and you have to have different probe sets for each fish, right? Different markers for probes for each region, and it's costlier than MLPA. So see, this is an example where you can see these markers which is higher than 1.5, that means there is trisomy. So this is trisomy 21. This is Y, this is a female, right? So Y is not there, and this is MLPA, and you know that this baby has Down syndrome. So when a baby is born and looks like Down syndrome, we have to give very rapid diagnosis, very fast diagnosis. So within 24 to 48 hours we will give the diagnosis that this baby has Down syndrome, and the outcome तुम लोग उधर बात करो. So because parents have to know that if the baby has respiratory distress, they might have a hypotonia, and what will be the outcome for them. If they have associated cardiac disorders, what will be the outcome, whether we have to treat, what are the associated conditions, like they have hypothyroidism, so we have to screen for that. So you have to give a very rapid diagnosis, and you know that for newborns there are new RBCs. Doing karyotype is sometimes very, very difficult for doing it in newborns. Similarly, this is one more where we did not know, sample just came from outside, and there was no diagnosis. We did for all subtelomeres, but they told that probably a down-like phases was there. Anyway, this is Down syndrome. You see that 21, these are 21. So 21 does not have a P arm, they are satellites. So this is just a proximal probe to the centromere, and this is the distal probe. So you see that this is also another trisomy 21. So now I start with a story where I learnt MLPA. So when I was doing my DM, so this baby came. Actually, we are screening for all children with intellectual disability. So this is a 2 years old male, and you can see that the baby has profound developmental delay and hypotonia and growth retardation, and he has a seizure. There was some facial dysmorphism. This is a cleft lip which has been operated. So we had no diagnosis, neither I had nor my teacher had. So, but we were doing one project on MLPA. It was my DM project, and karyotype was normal. So we did some EEGs, neurometabolic screen, MRI brain. So we had no clue. Then we were screening for subtelomeres. That means in the telomeric region, because they are gene-rich region. So we started doing this way back in 2007 or something. So MLP is a technique where there are mix of probes. You can amplify 40 to 45 targets simultaneously, and you can look for deletion duplications, and various probe sets are available. You need just a PCR machine and a sequencer for capillary electrophoresis. So this is a probe pair for each region. There are certain things called hybridization sequence, a stuffer sequence which differs in probe pairs, and a common PCR primer sequence, a forward and reverse on the either end where we'll amplify the probes. So that is why this technique is called probe amplification. We don't amplify the DNA, we amplify the probe. So you know that first there is denaturation where the two strands of DNA will get separated, so there will be different targets. So these probe pairs will go and bind to different targets in the genome. So here we have targets of all telomeres. Then there will be something called a ligation. So if these probes are these probes could hybridize if target is there, so they will get ligated together. So there is no gap. This is just nucleotide to nucleotide. There is no gap, but you require a ligase enzyme for ligation. Then we do the PCR of these ligated products, and there will be multiple copies of them. Then we run in a capillary sequencer, and we see these peaks. Previously, you cannot really see this manually, that this is small and this is the normal, or this is large and this is small. But we have to do some analysis in the softwares. Previously, we used to use this type of Excel sheets, but now it has changed. Now it is something called a coffalizer, and this is being provided free of cost once you buy the MLPA probe, or even if you don't buy, they will give you these through the internet. You can buy them. Then you do something called fragment analysis. Then you compare them through software only, and they will give peaks will look like this, and the output will be like this. Here you see. So the probe ratios, this is called a probe ratio is 1. So they are all normal, right? So anything beyond this 1.5 is duplication. Anything beyond this is deletion, that is heterozygous. So this is doses. We can have doses analysis through MLPA. So for that child, there was 4p deletion with our softwares. You can see this, that if you compare this visually, you can make out something. But as we were new, we actually did a fish of the 4p, which is very difficult to obtain. But we did and found that yes, in all cells there is heterozygous deletion. Only for one there was signal, the other was not there, and this is control. You see two signals in each cell. So the karyotype was relooked, and you can see a small deletion over here. The small white part because the terminal part is not dark, so is very easy to miss. So for 4p deletion, lot of samples might be missed just by looking visually on karyotype. So we did a FISH to confirm, and we relooked the child. This is called a typical Greek warrior helmet pattern of nose or the forehead. You can see a Greek warrior helmet. If it is owned, it will look like this. So this is very, very typical of this, and this is called Wolff-Larsen syndrome or 4p deletion syndrome. And our series, along with this, we had published way back in 2009, and we were the first to publish MLPA from probably from our country. So when I went back from here and I was working at CMC Vellore, then in Calcutta, I worked for quite some time. The second child I saw, I readily diagnosed that that child has Wolff-Larsen syndrome and looked at the karyotype, and we can see this terminal deletion. Again, we confirmed by FISH or MLPA. After many years, when I came back here, we saw another child with similar disorder, but again we missed because this child did not have cleft lip palate or very typical tonic posturing which those children had, and we missed. And again by MLPA only we could pick up this, and we kept on learning. So in a learning curve, you may miss things. And this is the child. Again, you see this Greek warrior helmet pattern of nose and forehead. So there are other common microdeletion syndrome. So this is called a pear-shaped nose. This is an adult. This is a child with cleft palate. So any pediatrician. Hypocalcemia. This is called velocardiofacial syndrome. So we recognize this easily sometimes, and you can see that previously we used to do FISH. So this is a control probe. This is this red region is 22q region. You see that it's not there, and there is heterozygous deletion, and it's there in a normal copy is there. Now what we do is a MLPA directly. We do MLPA because again FISH is costly, and sometimes in MLPA we screen for more than one disorders. So this is called Angelman Syndrome or Happy Puppet Syndrome. This is Prader-Willi, where there is obesity. This is a very typical recognized phase of Williams syndrome. We recognize these, and we'll just put, so this is, you see different phases. So we very typically recognize these children. This is Williams syndrome. They have some certain cardiac disorders, and what they have is hypercalcemia. And we have to tell, because they are small children, pediatrician will start them on vitamin D, calcium, multivitamins. So, but for them, once you diagnose Williams syndrome, you have to tell them, please don't give calcium. We have to do annual screening for the kidneys because they have hypercalcinosis, and the kidneys are affected if you give a lot of calcium. So, this is a very good example where you recognize a syndrome, do a simple test, and give a surveillance plan for the parents. So, Williams syndrome looks like this. So, you see that this is the gene at 7q. So, this is the typical genes, and there are deletions. This is a microdeletion syndrome called Williams syndrome. So, this is a very interesting story. This child came, and actually our colleagues, one of our colleagues sent me these photographs and told me, what does this child has? So, I told he has Williams syndrome. Then there is a person who was my colleague and a pass out from our institute only, Patil. He is a typical cardiac geneticist. He told no, he has velocardiofacial syndrome. So I and Patil started fighting, and the person who sent us was enjoying, right? Then what we did, that we told, okay, let us do a MLPA and find out. So sometimes you will have this dual phenotype where this child has two microdeletion, which is very, very uncommon, right? And phenotype may differ, but this is, see this, the marvel of this proves that we can do many things together, and this child has a dual phenotype, and we had published this in a good journal, American journal in 2015. So this is Williams, and you see that, as I have told you, there are other probe sets where you can confirm it. So this is a Williams syndrome where we found in a probe set where there are many probes together. Then there are dedicated probe sets for Williams. So we could find that yes, this child has Williams syndrome. For that we did to be very sure. And same for velocardiofacial. Again, we have another dedicated probe sets for velocardiofacial. We did it and we confirmed. These are certain other examples. A very typical facial gestalt. I still feel sometimes to diagnose this, but we have a large series of Smith-Magenis syndrome. Again, it is a common microdeletion syndrome, and you can look at MLPA, and we had published this. These are some of these common microdeletion syndromes, old data. We can use this for antenatal diagnosis. You can see here there is hypothyroidism and there is single nostril. Probably anybody can understand that there is single nostril, not even obstetrician or radiologist. Anybody can see and see there is single nostril and very small brain. So we had no clue. So we did for subtelomeres, right? Because we thought that it can be a chromosomal disorder. So we did for subtelomeres. And you see there is 13q deletion. This is called aprosencephaly or atelencephaly, where there is a very small brain, single nostril. And it occurs due to 13q deletion. So this is a representative chromosome, and you see that in this chromosome this part is deleted in the karyotype. So MLPA really can give a very rapid diagnosis when you await a karyotype. So for deletion duplications, as I have told you, it is very interesting. You know Duchin muscular dystrophy. Any pediatrician will know Duchin muscular dystrophy, or neurologist. This is the commonest neuromuscular disorder which we see. They have this typical Gower sign. They almost climb up, and it is very pathetic to see a child with this disorder. There is no treatment available as of now except for steroids to improve their walking for some time. But we have to give diagnosis to them, and this is where MLP is required. More than 60%, 60 to 17% are due to deletion duplications, and you cannot look by any other method. This is only one method where you can look. Previously we used to do, for deletions we used to do multiplex PCR. That is what I learned from Dr. Balraj Mittal, and it was really heartening to know that. But later on we have shifted to MLPA. Every lab has shifted to MLPA for DMD. Previously it looked like that. This multiplex PCR. Now you can see large number of deletions. This is a X-linked disorder, and in a male you will see probe set of 0, probe ratio of 0, because they have only one X chromosome, right? So these are the males with large deletions. Then you have males with duplications. Again you see that duplication will come around 2 because they have only one X chromosome for males. For sometimes you don't know, they came for some other thing, and a big family with so many male deaths, this X-linked disorder, and these two sisters came, and this is what that mother must be obligate carrier, and these two sisters came to us. When we don't find, because she has 2 X chromosomes, we sometimes do this to find out that she has Rett syndrome. This is one more example where you have this mesomelia. This is called Langer's mesomelia syndrome due to SOX deletion, and here you see they have short stature. They have some way of Turner syndrome because of SOX deletion, and we can also do it through MLPA. Sometimes you hit up in very different disorder. So this is a disorder where there is ambiguous genitalia. You can see a perfect female genitalia with a male karyotype, and this is a very rare disorder. With docket deletion we found with MLPA. Sometimes MLPA is required for other tissues as well. If somebody does not know, recognize this, nobody will find out. The blood karyotype is absolutely normal, but you can see this is a skin karyotype where we did, and we find a marker chromosome. This is tetrasomy 12p because I could recognize this disorder. This is called Peristal Killian syndrome. We do the same in skin, right? This disorder or this phenomena goes away from blood and it remains in the skin with time. So this is Peristal Killian. So if you don't recognize this disorder, we cannot we cannot do any test to confirm it. So use of MLPA we do for chromosome numbers, microdeletions, copy number variations. We also do for alpha thalassemia, because you know alpha thalassemia is something which is due to deletion, sometimes associated triplication with beta thalassemia will give rise to thalassemia intermedia. Beta thalassemia carrier state will give rise to severe form of thalassemia or thalassemia intermedia also sometimes. Then for certain single gene disorders we also do. And we use this technique for prenatal testing for DMD, SM and various disorders where we have found the mutation in the proband, and this is taking out amniotic fluid after 15-16 weeks, and before that we take the CBS sample and extract DNA, right. So there are certain disadvantages. Results depend on sample quality. Amniotic fluid sample, it is better to use lysates, but we definitely do extract DNA. They do not detect balanced translocations. Remember that cytogenetic microarray also do not detect balanced translocations. MLPA cannot detect all triploidies because it is something a dosage analysis. It does not detect mosaicism. Sometimes it will, like in the skin I have told, it is present in the mosaic form. Sometimes it will when the probe number is slightly above, but you have to confirm it with other with karyotype we have confirmed from skin karyotype only. And it is very difficult to develop new MLPA based test. It is in the hands of only one company who is sending this. So this is macroglossia and umbilical. So this is Bequid-Wedman syndrome, and this is one methylation disorder where we don't do a Sanger or anything, but again you have to diagnose it and do a MS-MLPA. So MS-MLPA is very similar to MLPA technique, only that you need a step of denaturation and it gets bifurcated into two different steps, and we do MS-MLPA. So the last pictures, what does this child has? Pediatricians. People will think that Bequid-Wedman because of the tongue and umbilical hernia, but this is for pediatricians. I always give example. So these are two different children with the same disorder. So this is congenital hypothyroidism. It's a very common disorder, and obviously with newborn screening probably the incidence is going down, but pediatricians have to recognize the disorder. This is not a genetic disorder at the face value. There might be underlying genetic causes, and the treatment is very, very important in very early infancy to salvage the brain function. So thank you so much. Thank you, Dr. Neetu, the funding agencies who gave us funds for my patients who comes to us, teaches me, my colleagues who work with me, many of them are faculty in different places, and mostly this is Brijesh who does MLPA for us, Shashank who does Sanger. So they are our technical officers and my team of bikers. So I am a bike enthusiast. So anybody can contact me if you want some anything for a patient or for motorcycles. So thank you so much. Questions अभी बाद में.
We'll have the next one. No, ma'am, we'll have the inauguration ceremony. I'll take it.
Absolutely a very pertinent question, and probably the most pertinent question is what would be the length of the gene. Like if the whole exon is deleted, the probes and binds to few nucleotides only, 20 nucleotides this side and 20 nucleotides that side. So even if single nucleotide is abnormal in the binding region, it will show non-binding. So it ranges from single nucleotide to many, like hemoglobin constant strain. There is a probe in alpha MLPA. It's a single nucleotide change. So it detects from single nucleotide to very large, but the extent we cannot make out if you do not have probes at different areas. Yes, 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 yes.
Thank you, sir. I'm sure we all will agree that that was indeed an enlightening and fun session. We now have our chief guest for the day with us and we shall proceed towards the inauguration ceremony. ऐसा शहर है हमारा जहां सपने भी भरते हैं उड़ान, उड़ते हैं परिंदे सुबह से यहां, कहते हैं इसे नवाबों की शान। आसमां की क्या ताकत जो छुड़ाए लखनऊ हमसे, लखनऊ हम पर फिदा और हम फिदाए लखनऊ हैं जनाब। इसी तहजीब के शहर लखनऊ में स्थित श्वेत के सम्राट में आप सभी का हार्दिक स्वागत है। On this note, a very good morning again to one and all present here. It is my honor to welcome you to the day 2 of the workshop on advances of cytogenetics organized by the Center for Advanced Research, King George's Medical University. We are honored to have amongst us the Honorable Registrar of our university, Mrs. Rekha S. Chauhan, as the chief guest for the day. We welcome you, ma'am. It is rightly said, even a single lamp of knowledge has the power to dispel the deepest darkness. On this note, I would like to request all our dignitaries to kindly light the ceremonial lamp. Ma'am, sir, please. Thank you, ma'am. Having invoked the blessings of Goddess Saraswati, I would now like to hand over the proceedings to our honorable chairpersons for the day to continue the session. Ma'am, please.
So moving on to the next lecture series, we have Dr. Swasti Sinha with us. She is assistant professor in clinical hematology in KGMU. She is first diplomat of National Board in Hematology. She is also a technical assessor and inspector for hematology and immunohematology for NABL, Quality Council of India, credited with setting up tertiary level testing hematology facilities in large corporate setups, national faculty speaker in hematology and quality management, was nominated as International Liaison Counselor for International Clinical Cytometry Society in 2018. Her major interests include myeloproliferative and myelodysplastic neoplasms, preventive hematology, precision medicine, and cracking challenges and diagnostically difficult hematology cases, both benign and malignant. So let's have Dr. Swasti with us.
मिरर करिए मिरर
We apologize for the inconvenience due to technical issues. Dr. Swasti ma'am's session has been postponed. I now invite our chairperson for the day, Dr. Rashmi Kushwaha ma'am, to kindly introduce the next speaker. Ma'am, please.
Due to some technical glitch, we'll be moving ahead with the next session by Dr. Nuzhat Hussain. Ma'am doesn't need any introduction, but for the new students here, I would like to tell that ma'am is Dean, Professor and HOD Pathology, Dr. Ram Manohar Lohia Institute of Medical Sciences. Her fields of interest include oncopathology, cytology, neuropathology, and genetics. She has more than 312 publications to her credit, out of which 227 are in international journal and 85 in national index journals. She has 2 textbook chapters and monographs to her credit, 5 book chapters, multiple international visits, trainings and lectures, and she is a very good teacher. Ma'am, we welcome you.
So at the outset, I'm doing something odd, which I've never done before. I'm giving you a choice of a lecture. So because I was just going through the presentations, and I thought that this was entirely dedicated to cytogenetics. I've done a short stint in cytogenetics as a part of my work, and that's what I put into the lecture that I was supposed to be taking today, which is basically radiation biology, looking at cytogenetic changes post-radiation exposure. We are currently doing a lot of work on liquid biopsies, and we are looking at liquid biopsies in tumors like gallbladder cancer, which we've done major work on, and then several other tumors like oral cancers, breast cancer, etc. So sticking to one, which is the cytogenetic damage in radiation exposure, but if you have interest in liquid biopsy, I'm happy to take that up. So that's question 1. Cytogenetics? Okay, great. So, so I have no conflicts of interest to declare. I'm not a radiation specialist. I have just looked at radiation damage in patients exposed to radiation. So this was a work which was done in a thesis under my guidance, and that is the major part of our work that I'll present, and I'll also tell you generic things about what radiation does to cytogenetics in the body per se. So radiation can cause damage, we all know that. The types of radiation that you can have can be alpha radiation, beta radiation, gamma radiations, X-rays, and now you have proton rays and neutron rays and so forth. The first reports on the harmful effects of radiation actually were way back by Mueller, who noticed chromosomal aberrations occurring in the Drosophila gene after exposure to radiation. And then radiation and cancer is something that we keep hearing. And we know that the first radiation-induced skin cancer was reported in 1902. And then after that, you have radiation-induced leukemias, you have bone cancers, you have liver cancers, you have leukemias. So all these are malignancies which we know are definitely associated with radiation. So the question arises, what kind of radiation do we normally, all of us, get exposed to? So there is a background radiation that is present always, all the time. Then additionally, we get exposed to radiation whenever we undergo medical procedures. Okay, so if you are undergoing an X-ray, we are undergoing a CT scan, and sometimes you're undergoing an angiography, a CT angiography, you will get exposed to radiation, and then you get exposed to high radiation if you've already had cancer and you are undergoing radiotherapy. So in our, people around us in a hospital, you can have normal people exposed to only background radiation. You can have people who are undergoing diagnostic tests like CT, and they are getting exposed to radiation. And then you have your set of patients who are undergoing radiotherapy. So what we wanted to look at was the changes that can occur in a normal subset exposed to background, in a subset exposed to low dose radiation, which is the diagnostic radiation, and in a subset exposed to the high dose radiation. So what kind of changes? We know that radiation causes single strand breaks in the DNA, and it can also cause double strand breaks in the DNA, and therefore you can get mutations, you can get translocations, you can get deletions because of radiation exposure. And that's what you can possibly look at in the chromosome per se. So there are like gross changes that are occurring if you are able to see in the chromosome or the cytogenetics as such. So how are these radiations? They are harmful. Just for the very youngsters here, a very simple picture. What can happen after radiation exposure? The cell can undergo repair. Damage तो हो गया, लेकिन उसका repair भी हो गया. Okay? Then it can undergo a misrepair, which means that a mutation comes in, or it does not undergo repair, it dies. Both the two ends are good. Either it's undergone a repair or it's gotten no repair, it dies. So you no longer have that damaged cell or that cell which is going to be mutated lying in your body. But suppose the mutation occurs and it survives within the body, then you can have the subsequent things which can happen, and one of them is cancer. So the data source from where you can get the material can be either early radiation workers, where then people did animal studies. There were medical personnel who were working with radiation for either diagnosis or radiotherapy. Again, they have an exposure. You have patients who are on high dose radiation, I've already told you. And then you had these disasters, like you had Hiroshima and Nagasaki. And even today, generations after, their grandchildren have got cytogenetic changes, they have got mutations, and they have a way higher incidence of leukemias and thyroid cancers as compared to the normal population. After the Chernobyl disaster, you had that really huge peak in thyroid cancers which happened, and many, many decades later, you can still see the changes which are persisting in these cases. So again, the question here, you have a low dose radiation exposure to CT scan, but is this change going to persist? So what is more important clinically is a persistent change. Okay. So coming again to this CT scan or this radiation exposure that you are getting in the diagnostic setting, in the 1980 per capita dose that you were getting, if you just look here at the CT scans, it is just only 0.03 millisiever is what the generic dose was being given to the population at large. And now in 2006, you have a lot more exposure to CT scanning, to radiography and all as such. So we know that diagnostic procedures are going up, and hence we require to know what is the DNA damage which is occurring because of these diagnostic procedures. We know high dose radiation causes it. Hiroshima में हुआ, Nagasaki में हुआ, Chernobyl में हुआ, we know high dose में होता है. But we don't know exactly what happens in the low dose, and do we need to take a precaution when we are doing the low dose exposure. So diagnostic radiations, if we look here, in CT scans you have a 10 to 30 millisiever exposure depending on the number of cuts that you are doing. In angiography, the exposure is higher. It goes up to 50 millisievers. And then also, if you see those patients who have undergone a head injury, they will have an initial scan to see what the extent is, and a lot of times the scans, they are repeated, like after 2 weeks, again after a month, after 6 months. So this repetition and the gap between, so the damage because of radiation happens, number one, because of the extent of exposure, number two, the multiple times of exposure, and number three, the gap between those multiple times of exposure. So, and they also say that if the radiation goes from a low to a high intensity, the damage is worse rather than if you do a high intensity to a low intensity. So probably it's building up that chain of damage that is occurring in the body. And this is a study from the New England Journal, which shows that this is how the CT scan exposure is going up, and this is how the increase in the cancers and the leukemias as well as some digestive cancers and all, they are occurring. So people have started looking at this. I don't want this lecture to scare you and think कि अब CT scan कराना नहीं है because इसकी वजह से cancer हो जाएगा. That's not true. We are just looking at things. The end point of this should be that do we need to exercise some precaution before we write it so easily on our prescription, okay? So also the thing is that we are also exposing children to the scan. So though our study was limited to adults, but then again we also need to know, because children, we know the genes are more fragile. So whether it's going to kind of happen more in children, this exposure, we still need to know that. So diagnostic radiations, we've already discussed, can occur because of CT scan, because of angiography, because of mammography, several procedures which you are undergoing. And how this is going to damage, you can have a low intensity, which usually causes the single strand kind of breaks, and you have the high intensity where you can get like multiple double stranded breaks, you can have intra-strand breaks, you can have complex single strand breaks. So it's more complex the more high the intensity and the exposure is. So what are the aberrations you can look for in the chromosomes? So in the chromosomes, the most common thing that you find are these dicentrics. You have a centromere in a chromosome, right? So sometimes you can find some chromosomes with 2 centromeres, all right? So those are known as dicentrics. What's usually happening here is, जो आपके 2 chromosomes जो pair बनाते हैं, they are not separated from each other properly, and they separate, they break at a point which is later. So दोनों centromeres तो एक में रह गए, and एक ये जो piece आपको दिख रहा है अलग से पड़ा हुआ, this is a non-centromeric piece or an acentromeric piece which is also there. So these dicentric chromosomes you can get centric rings. So here there is like 2 breaks which are occurring on the same arm, and then this arm, those 2 breaks, they unite to each other and they form a ring. So you can get these ring chromosomes or centric rings. You can get acentric rings as well, or these kind of, you know, these. You can get double minutes if it's like really small pieces which are breaking out. Now this is one precaution that I need to put in, are what are known as rogue cells, okay? So these rogue cells, they are defined as cells which are present in metaphase plates, and इनके अंदर अगर आप देखेंगे तो आपको बहुत सारे damage changes दिखेंगे, double minutes भी दिखेंगे, dicentrics भी दिखेंगे, ring forms भी दिखेंगे, but these are, you know, there will be no history of any exposure of any type in these patients, okay? So people followed up all those Chernobyls and the Nagasaki ones, and maybe 3rd, 4th generations had these rogue cells, but also normal people have these rogue cells, and the number of these rogue cells are very few. So they say that if you're finding just one cell which has got so many changes and it's not repeated in other cells, in that case you don't attribute it to the radiation exposure or whatever chemical exposure, whatever you are studying, okay? So this is something that we need to know. So those are unstable aberrations like the dicentric, the acentric, those ring forms. And then you can also have stable aberrations, which is like, you know, one part breaking up and going and shifting on to the other. So that's like a reciprocal translocation. One part breaks, exchanges, that is reciprocal. One part breaks, just goes to the other side, it is non-reciprocal translocation, okay? So you can have interstitial translocations where if you see here the chromosome 1 has been painted, and is chromosome may only a part of the 1 has come here, right? So this is like an interstitial translocation. So you can look at these translocations, you can look at stable, at any type of translocations. You can also, you have chromatid type aberrations which can occur because of radiation exposure. These chromatid type aberrations and chromosome type aberrations में क्या फर्क होगा? Anybody? Chromatid type aberrations and chromosome type aberrations. Sounds like the same thing? Yeah. So if only one arm of your chromosome has got the change, that is a chromatid type aberration. If both the arms have got the change, that is a chromosome type aberration. Okay? So in a chromatid type aberration, here if you see, there is like a deletion, and this is an interstitial deletion, ये बीच में हो रहा है. Or you can have a terminal deletion. So you can have deletions which can occur in the chromatid type aberrations. You can have symmetric interchanges. So you can get a chromosome which has got 4 branches. Okay. So these are the kind of changes that you will study. Then the other thing that happens because of damage is what is known as micronuclei. How are these micronuclei formed? When you see the cell is dividing, the chromosomes are getting pulled on both sides and दोनों तरफ cells बन रही हैं नई. So sometimes this chromosome material is left behind inside, in the middle. Okay. And that leftover chromosome material can be either a full chromosome or a part of a chromosome, and this collects separately in a small nucleus like round figure, and that is known as a micronucleus. Okay. So now if you can see, this is a cell, it has got 2 daughter nuclei and doesn't have a micronucleus, 2 daughter nuclei and 1 micronucleus, 2 daughter nuclei and 2 micronuclei. So these micronuclei again are signs of abnormal mitosis that is occurring and again of damage. So if you want to assess damage, you can do karyotyping, you can look at the chromosome, unstable and stable aberrations, or you can look at the presence of micronuclei in looking at this radiation damage. So the other methods of estimating radiation damage is that in these cells, normally this H2AX is present, and after radiation exposure this becomes a gamma H2AX. So if you can do the levels of gamma H2AX in your peripheral lymphocytes, then again you can assess that there is a radiation damage that has occurred. And the other thing that you can do is also when radiation damage occurs, we just discussed that there are fragment breaks. So if breakage is occurring, normally then you will get small size fragments which will be present because of a damage. Okay. A fragmentation otherwise usually gives rise to longer size fragments. So if you're getting a lot of small size fragments, you can amplify one particular gene, multiple probes, and look at the size of the fragments that you are getting. And if the number of small size fragments is higher, again you can assess that some damage has been present. So what we looked at in this radiation damage was at the frequency of DNA damage after low dose exposure in peripheral blood lymphocytes. We looked at the methods, as we said, the gamma H2AX, micronuclei, chromosomal aberrations, the presence of fragments. All these 4 methods you can use for assessing the damage. So we compared these 4 methods as to how sensitive they were in picking up this damage, and then we tried to establish a dose relationship. That एक बार CT हुआ था तो कितना damage आया, multiple times CT हुआ तो कितना आया, angio में कितना आया, and then ultimately जिनकी radiation therapy चल रही थी उनमें कितना damage आया. Okay. So what did we get? We took 100 samples, 25 were non-exposure, 50 were low dose radiation, 25 were high dose. We could say दोनों ends पे sort of controls थे. पता था इसमें कुछ नहीं आना चाहिए और उसमें ज़्यादा आना चाहिए. Our main question was the low dose. And in the low dose we took 3 groups. Ones with only single CT exposure, ones with multiple CT exposures, and then some who were undergoing angiography, because again there the single higher exposure is there in the low dose version. So any exposure less than 100 is considered as a low dose exposure. So we collected the samples, and then all these tests underwent a qPCR, which a long PCR basically for sizing the fragments, gamma H2AX assessment through flow cytometry. Then they underwent the karyotyping, and then with the lymphocyte cultures, and then we look for the micronuclei also in the lymphocytes. So the dose quantification was done very scientifically. The CT when done at the end of it gives you a value as to how much exposure, how much radiation has been given, and from there you can calculate the dose, the radiation dose that the patient has received. So 4 methods, I am repeating again, these 4 methods they were compared. The blood was collected, and this blood was cultured, and then this was harvested, and the gene staining was done in one smear to look for the micronuclei, we did the karyotyping, and then also some of these cells, they were collected for doing the H2AX assays as well as for the qPCR. And these were the scoring criteria that were used. I will just show you the findings that we have got. And so this was the general characteristics and the radiation exposure. And you can see here that the exposure, the group 2 is your low dose, and you have the group 2A, which is single CTs, and then this is multiple CTs, and this is the one with the angiography. So, and you can see that this is the radiation dose that has been given to them. So this is nil, this is 23,000, so that's huge. And this was like the single dose CT, multiple doses, and this was the radiation exposure because of the angiography. And these are like no exposures, and you can see no micronuclei here, and few cells had micronuclei in the low dose, very few micronuclei, and in the high dose you had a lot of micronuclei that were present. And then we did like the percentage of these micronuclei, and this is how it was working, actually very much in the direction of the dose that was given. And you can see here that the maximum was in group 2, where you're giving multiple CT exposures. And the results of the chromosomal aberration assays again were, we looked at the metaphase plates, and this is the normal. And then you can see here, you can again see the dicentrics here, you can see the dicentrics here, okay, in this particular metaphase. You can see the deletion that is happening here, you can see the gaps in insertional deletions that are happening here. So all these low dose exposures were actually giving rise to this. But, and so makes things a little scary, but it's not as much as it is in the high dose. The gap, of course, in the study is, and which should be done, was to catch these patients 6 months later and then see whether these changes were persisting. Because as I said, अगर repair हो गया तो कोई problem नहीं, cell death हो गई तो कोई problem नहीं, अगर persist कर रहा है, that is where the problem lies. So these we could have followed them up. Here you can see a very nice tri-radial or a tri-radial chromosome. You can see 3 branches here. And the results of the gamma H2AX assay were quite interesting. This is actually this was a novel technique. I mean, people normally don't do H2AX using a flow cytometer. So what we got was an antibody against the gamma H2AX, and then we used that antibody, we used the CD45, and then we gated our smears for the CD45 positive gamma H2AX positive cells. And you can see here that this is the group 1. This is the group 1, okay, this is the group 1, and very few cells are there with the gamma H2AX. And this is the group 2A and B and C, and the cells are increasing. And again, see, this multiple CT scan is giving you way more gamma H2AX. And so we compared between the groups and the exposures, and if you see here, there is a significant increase in the low dose multiple as compared to the normal controls. So these patients who are undergoing multiple CT scans really need to be kind of controlled on. And then we also thought, I think the age should make a difference, because the repair mechanism is way better if you are under 50. So if I get exposed to a lot of radiation, maybe, but then I may not have enough time for the cancer to develop after the mutation. So it's both ways. The point is the repair mechanism obviously is better. So we divided our data up into the age-wise thing. So patients under 50, under 40, we didn't find any significant value, but in the high dose radiation, it was a little significant, saying that, you know, the ones who were above 50 had more damage as those compared to the low dose ones. So all this got published with the new techniques, etc. And then we also did the qPCR. As I said, we look at the long fragments, we look at the short fragments, and we do a relative amplification of the long versus the short. And these are the gels which are showing you the short fragment and the long fragment, and then you quantify and you do a percentage. And again, the direction was exactly as the doses were going. So all 4 tests actually told us the direction. and they said that multiple CT scan exposure was giving us worse results as compared to all other low dose exposures. And these were the 4 methods we compared. And when we looked at the sensitivity and specificity of detection, then the chromosomal aberration assay, and that's the topic for today, gave us the best sensitivity and specificity for the measurement of the damage due to the radiation exposure. And then when we combined the tests, we decided then we really want to look at this, which 2 tests we should do. So we thought that the micronucleus assay and the gamma H2X are both practical, and they're both giving pretty good sense and spec. So जब भी आप कोई टेस्ट करते हैं ना, तो आपको ये भी देखना पड़ता है कि वो कितना लेबर इंटेंस है, उसमें कितना खर्चा हो रहा है. So the labor intensity of chromosome of karyotyping definitely is high. Okay, and so if you can get a test which can do like Dr. Sab just said, कि MLPA may work. So if you can do MLPA instead of doing NGS or looking at the sequencing, if you can do micronucleus assay and gamma H2AX by flow cytometry instead of going for the karyotyping, it just might work equally well. And then finally, as I've already mentioned throughout, we had a dose relationship between the DNA damage and the intensity. So we also did this in vitro, and we took these tubes with blood and we exposed them to different doses of radiation in the LINAC. And we exposed them to 0, 0.10, 0.25, 0.5, 1 and 2 gray. And then we looked at the micronucleus and the chromosome aberrations in these cells. And you can see here, this is like, just a pictorial depiction of increase in changes with the increase in the dose given in the in vitro samples as well. And this was what the percentage of the dicentrics and the gaps that were observed were there in each of the groups, and again showing you a similar kind of rising pattern that was present even when we did this experiment outside the body. So that's the micronucleus assay results, and these are the dose response relationships were actually going in a graph with each other. And so that was a model that we published for evaluation of genomic instability. So in conclusion, DNA damage occurs because of low dose radiation. Low dose with multiple exposures is not a great idea. So I think there should be some gaps in between the CTs that are getting advised, and if you can advise an MRI instead of a CT, it might be a better idea. And these cell cultures in the chromosome assay technique is the most sensitive, but equally good is if you combine the micronucleus and the H2AX assays. And the question at the end of this is that should we exercise more precaution in advising multiple CT scans, especially in conditions where they have low clinical utility. Thank you very much. Any questions? Oh, sorry. Thank you. Yes, sure. No idea. That was not the research question, and we haven't really looked at the gaps. So these are the gaps in the study which somebody else may want to follow up. So if you actually look at the next step would be to take patients with multiple exposures, look at the gaps that are occurring between the CT scans, because we just took over 6 months. अगर किसी के 2 से ज़्यादा means 3 कम से कम CT scans हुए थे, so we included that as multiple exposure. You can then create subgroups saying at 1 month, at 6 months, okay, at 15, 1, 2 months, like close exposures. Overall, larger exposure, how much dose exposure is there, number of CTs. Also, CTs are different. See, if you're doing a 5 mm cut or you're doing a smaller cut, the exposure is going to be different. So, actual exposure calculation and stratification of patients with gaps in between, that is a gap in the study which needs to be studied. Yes, Preeti. but clinically they're getting it done every month. So and then there's an explanation. They say that it's required. Like for instance, all the head injury patients, for instance, all the brain tumor patients, they get it done so frequently. And there is a clinical indication. The point is that should we substitute with an MRI? But there are certain things you see better in a CT. Yes, undergraduates. What do you see better in a CT as compared to an MRI? Go back study. One is calcification for sure.
So thank you, Nizat ma'am, for wonderful lecture. Our next speaker is Professor Nisa Singh. Ma'am is unit head and in charge of genital cancer control unit at King George Medical University, Lucknow, vice president and vice president at Association of Gynae and Oncological Society, vice president at Lucknow Obstetric and Gynecological Society, secretary at various conferences, joint secretary at AOGIN, executive member at UP chapter, member at FOXY. Ma'am has various awards. Best is at 2015 Bharat Jyoti Award and has her experience approximately 22 years. So over to you, ma'am.
Thank you so much, Dr. Rajni. So very good afternoon to all of you. And the topic that I have taken is more of a clinical one, being a clinician. But there is a lot of role of genetic testing, and actually in many centers it has now become the routine clinical practice rather than only limited to research projects or this thing, where we need to reach actually for our university also. So for gynecological cancer, so I'll be talking about the importance of risk assessment, genetic testing, and the role of screening also. Once you find one, then what is the role of screening for other cancers, and some important syndromes which are there with more details. So when we say genetic testing, of course, it is the hereditary gynecological cancers in which it is leading. Hereditary cancers will be the ones where there is a familial predisposition. But there are certain syndromes in which more than one cancer will be, the risk will be increased for having those cancers. And among all gynecological cancers, it's mainly the ovarian and the endometrial cancers which have genetic predisposition and which fall into some of the syndromes which we need to look at when we are dealing with these cases. 5 to 10% of uterine and 10 to 15% of ovarian cancers are due to hereditary gynae cancer syndromes. And most of them will have autosomal dominant inheritance, and onset will be at a younger age as compared to the ones who are not due to cancer syndromes. So the risk assessment ideally should be done by the basic clinician, the general OB/GYN, when they get any patient of ovarian cancer or endometrial cancer, or a woman comes and she says she has a family history, and then the assessment is required. So the important points that need to be taken care of are you have to make a pedigree chart, and you have to see whether the disease is present in the first degree relatives, second degree relatives, or the third degree relatives. If it is a kind of some unusual kind of malignancy, and both the maternal and the paternal sides have to be seen. Is there a particular ancestry, like for hereditary breast ovarian cancer, it's the Ashkenazi ancestry which is there. So somebody who has, for our place migrated from that side. Age at diagnosis, as I said, younger age, and the type of the primary cancer. Some histopathological types are more prone to be associated with mutations. There will be some more additional clues that you get in the history. More than one type of cancer in one patient only. If you find, think about some kind of cancer syndrome. Multiple primary tumors in the same organ, or an unusual presentation like a breast cancer in a male. It should raise your antenna that maybe there is some kind of genetic predisposition. Triple negative breast cancers which are ER/PR negative or HER2 negative, or there is a HER2 new overexpression. Epithelial ovarian cancers now are important, especially the serous histology. They say that now all the guidelines say that all cases of high-grade serous histology should have the genetic testing done. They should be offered because of the very high risk of this genetic mutation in those. And another thing is the advantage that we get. I'll come to that. There are advantages of these testing not only for the family but also for the patient herself because of the targeted therapies that are available nowadays. So once you find this kind of picture in a patient whom you think should be assessed, has a high risk on the assessment, then they should be referred to a geneticist, specialist, clinician or a nurse, somebody who is trained into counseling before the testing goes, so that there is a good pre-test counseling and there is a good post-test counseling. And the uptake is much better when a trained person does it. Though we do it as clinicians, we have lack of time and still we are not able to give so much time and privacy or everything. So there is a need to have separate hereditary cancer clinics in at least in some of the specialties where we have this higher risk, higher number of patients which we possibly will find. And so this increases the acceptance. Nowadays commercial testing is available. Many times patient will go and get the test done themselves. The problem is that then what to do? Because they didn't have a pre-test counseling, they are confused, they are very much worried, and that's why it's important that there is a pre-test counseling, then the test, what test is required, from where it should be done, and then the post-test counseling, and then the management should be done. So who should have a genetic testing? The best person is the person who is suffering from one of those cancers rather than the family members. So the first step is to find a family member who has had one of these cancers. So there you will be able to do both the germline mutation that is in the blood test, or if the patient, the tissue is available, you're going to operate, or then the somatic testing can also be done. So if more than one family member is affected, the one who was affected at a younger age group should be taken for that. And or the one who has bilateral disease or multiple primaries, or the one who is more closely related to the person in concern. So if the affected member is not available, then only we should go for the testing of family members of those who already have a known genetic mutation in the family. Germline and somatic, as I said, germline testing from the blood, it means that the abnormality is present in all the cells, while somatic testing is on the tumor tissue, that the abnormality is in the tumor tissue only. So that will help you in the targeted therapies decision, but for the family prevention and risk reducing approaches, it is what is required is a germline testing. Then only you can say that it is familial, and therefore you can do the prevention, screening and the preventive approaches. So the importance of screening is, as we understand, so screening will be in the same patient also for other cancers and also in the family members for any of those cancers. So screening is, this is the importance of screening, so that you can counsel for cancer prevention, for the fertility prospects, and also for the cancer surveillance and targeted therapy. And you can tell the risk of transmission in the of the pathogenic variants to their offsprings. Now coming to some of the most common, the two most common syndromes that are there among the where gynecological cancers are involved are the hereditary breast ovarian cancer syndrome and the Lynch syndrome. These are the two most common, and the rest are relatively less common. So I'll just mention them briefly, but these two I'll talk about. So the hereditary breast ovarian cancer syndrome, here there is an increased risk of female and male breast cancer, ovarian, fallopian tube and peritoneal cancers. Apart from that, less chances of prostate, pancreatic and melanomas also. And about 23% of the ovarian cancer is related to hereditary conditions. So ovarian is much more commonly. There is a term known as the site-specific ovarian syndrome, which is a subset of the hereditary breast ovarian cancer syndrome. No gene has been implicated, but only the ovarian cancer will be there in these cases. So that also may be there. So as you see, with BRCA1 and the BRCA2 mutations are the major mutations that have been known for a longer time, but now few more mutations are known to be part of to causing this hereditary breast ovarian cancer syndrome. And with BRCA1 mutation, the risk of breast cancer is about 50 to 60% and ovarian cancer about 40 to 65%. With BRCA2, it is relatively less, 40 to 55% of these women will have breast cancer, and 15 to 25% will have ovarian cancer if they have this genetic mutation in their body. So these BRCA1 and BRCA2 proteins, they actually play a major role in the DNA repair mechanism. So if there is a mutation, then that repair doesn't happen, and therefore there is a risk of these cancers, and these are usually high grade serous and endometrioid carcinomas that are there. This is the peculiar aspect, as I said, the type of cancer also. So particular histological types will be seen in this, and the other genetic mutations that I was just talking about, the cursor, okay, it comes. Okay, are the CHEK2, RAD51C, 51D, BRIP1. So there are some more over the years which we have come to know are part of the hereditary breast ovarian cancer syndrome. But the main ones are the BRCA1 and the BRCA2 only. And how there is an interplay of all these genes in the DNA repair mechanism. So any of these getting mutated leads to the increased risk of malignancy. And then these are the NCCN guidelines that women who are affected with following cancers must go for genetic counseling and testing. So any woman who has high grade epithelial, ovarian, tubal, peritoneal carcinoma, if there is a breast cancer diagnosed below 45 years of age, breast cancer with a close relative who had diagnosis at an early age. So there are clear-cut criteria which, according to which in our clinical practice we feel there is a large number of women who should have this genetic testing available. We did a study in 2015 in our center, 66 cases of ovarian and 44 breast cancer, and we found 11 patients who had a very strong family history, and there was a definite need for genetic testing to be done. So risk assessment is the first step. When you do that, then only you will know that how many will actually benefit from this. And then the preventive approaches and all, of course, will be there. So the screening methods for breast cancer will be mainly, if somebody has this mutation, then how will you screen them for the other cancers? So for breast cancer, it will be the monthly breast self-examination and then annual clinical breast examination, annual mammography, starting at the age of 25 if somebody has that genetic mutation. For ovarian cancer, unfortunately, we do not have very good screening methods, but still you can go for an annual transvaginal sonography with CA125 levels or from 35 years or something. So problem is that it is picked up, it just develops and it's difficult to. So we don't have any recommended this thing, but one who has the mutation there, this is what is advised. For melanomas, it will be individualized based on family history. For pancreatic cancer, no screening is recommended. Then risk reduction strategies are available. Women who are at high risk of these malignancies, for ovarian cancer, we can do bilateral salpingo-oophorectomy, and very good responses. Gross reduction in the risk of malignancy has been seen with that. So this is what we have to offer. A simple laparoscopic bilateral salpingo-oophorectomy can be done in these women if the testing is there and we know they stand high risk. Or actually now many recommendations say that even with family history, if it is there, you can actually go ahead for that. But it's always better to have the genetic testing. And only the risk of primary peritoneal carcinoma still remains, which is very less, 1 to 6%. So they need to be on follow-up still. And we do it at, for BRCA1 positive, we do it at 35 to 40 years after family completion. For BRCA2, around, we can wait up to 45 years. So the therapeutic advantage that I was talking about, the targeted therapies, nowadays we have the PARP inhibitors which work very well on the these BRCA positive cancers. So therefore, if we have this testing, we can offer this. It's a costly drug, but clearly shown evidence is there that the maintenance therapy with PARP inhibitors increases the survival. You can see in this graph that there is a significant difference in the long-term survival of women who were put on PARP inhibitor maintenance therapy. So these are the advantages of the genetic testing that we can offer to the patients. Coming on to the Lynch syndrome, that is the next common one which involves gynecological cancers, and this is the hereditary non-polyposis colorectal carcinoma. Here the major cancer is the colorectal cancer, 60 to 85%, and the others are endometrium and ovary. Endometrium is more commonly involved as compared to ovary in this, but if it is there, then again we have things to offer for both the management of those cases and also for preventive purpose. Lynch syndrome underlies approximately 5% of the endometrial cancers, only about 1% of ovarian cancers. But these will become the presenting malignancies in 60% of the cases of Lynch syndrome because of the clinical features, abnormal uterine bleeding or something. So they will be the presenting malignancies. So considerable benefit, as I said, for these cases. So the cause is the germline mutation in one of the DNA mismatch repair genes, MLH1, MSH2, MSH6, PMS2. So these are the, and actually there is a mutation in the MMR gene which causes microsatellite instability. Tumors can be screened by immunohistochemistry also, which is the advantage, and or by the PCR test. But for familial disease, you require a germline mutational testing, as I said before. Women with these mutations have a lifetime risk of endometrial cancer up to 30 to 71%. That's quite high. So these are the distribution of the various different types of mutations in the endometrial cancer or the ovarian cancer or the colorectal cancers. And screening, again, they say that all women, all patients of colorectal cancer should be screened for Lynch syndrome, and either by a direct germline testing or the MSI testing of tumor specimen. Clinical characteristics also, it is more common in the lower, so this should raise the suspicion if it is in the lower part of the colon. So these are the things that they have to look for. And then there is, this is the flow chart, that how do you go about, what steps do you take. So if there's a tumor tissue, you first do the IHC, and then by IHC, if you have MLH1 or PMS2 protein absent, then you do the MLH1 promoter methylation testing. If it is hypermethylated, then the risk is not there, but if that is normal, then there is a high risk of this case being a Lynch syndrome. And similarly with the microsatellite instability analysis, you can find if it is MSIH, and then again doing the methylation, you can know that the chances of Lynch syndrome is there or not. There are revised criteria for diagnosis of Lynch syndrome, the Amsterdam, and I'll not go into those details, but these are the the criteria by which you diagnose that. And then there are screening guidelines for colorectal cancer, colonoscopy every 2 years. So these are the benefits that we get once we know that this is a case of Lynch syndrome. So similarly for CA endometrium, some studies support a universal screening and others as per the clinicopathological features. And then if it is present, we can offer hysterectomy and BSO to the LS mutation carriers. That is what the advantage to those women is through this genetic testing. And then therapeutic advantage of genetic testing, many of you know that nowadays the molecular classification that has come up for endometrial cancer is completely based on the molecular testing, and based on that, actually on the biopsy tissue itself, if we get the information about all this, we will be able to classify and prognosticate the case, and depending upon the age of the patient, we can decide whether we go for a fertility preservation surgery treatment, which is available for C endometrium for the early stage grade 1, or we go for a radical surgery, and what will be the prognosis later. So there is a lot that can be done in endometrial cancer with the testing, with these tests on the endometrial tissue. So this is the benefit that you give to the patient per se, and the rest was about the mutations, the benefit to the family members. The knowledge of that is important. The other less common ones are like the Cowden syndrome, which is a PTEN gene mutation. Hematoma tumor syndrome, it is a part of the PTEN hematoma tumor syndrome, and mutations in the PTEN gene cause the chromosomal instability. And lack of PTEN expression, again that can be seen by the IHC itself, will help in the diagnosis. And it has a high risk of both benign and cancerous tumors of the breast, thyroid, endometrium. So it's the endometrium from our side that is involved in this. These are some of the simple characteristic features which can be seen externally, like the pigmentation on the lips, and then the cobblestone appearance of the tongue and on the gingiva, where the the risk assessment and then going for the genetic testing. So this clinical knowledge should be there. And then prevention of the hereditary, in this case, this again the screening and prevention, the strategies will start early, about 30 years of age. And then for endometrial cancer screening, again the annual TVS and the endometrial biopsy. Characteristic feature is Cowden syndrome related endometrial carcinoma will be in very young, maybe in the adolescents. So if you find an endometrial carcinoma in an adolescent, high suspicion of Cowden syndrome, and therefore the analysis should be done. Another one is the Peutz-Jeghers syndrome, where you have the STK11 and the LKB1 gene mutation present, and there will be autosomal dominant gastrointestinal polyposis disorder in this case. And among the gynae cancer, here it is the cervical cancer. It is the adenoma malignum which is seen in this syndrome. So if you have that kind of patient, and if there is any family history or something, then you have to, or if you have this kind of feature which is seen in the picture, pigmentation on the lips again raises the suspicion. So annual screening for cervical cancer in these women, and CA breast, as we said before, the monthly BSc, and then starting very early age group, because you need to detect it early and treat it early. Risk reducing surgery benefits for gynecological associated with Peutz-Jeghers have not been estimated, and therefore they do not recommend any kind of prophylactic surgery in this case. Some very less common ones are ataxia telangiectasia, where you have uterine and breast cancer that may be present. But here the ovarian cancers, if they are present, it will be the dysgerminomas. So that these are the differences, you know, with different syndromes, it's different histological type that will be there. Another one is the Dicer-1 syndrome, where you have gynandroblastomas and the Sertoli cell, ovarian cell tumor that will be there. So this is just to make you all aware that these are the possibilities, and one has to look for these things. Availability of all these tests probably may not be available, but I personally feel that it is high time that we have at least BRCA1, BRCA2 testing and the Lynch syndrome testing in the centers which are treating these patients. So this is just a summary. And coming to the implications and the prospects, availability of genetic testing at nominal rates for routine clinical practice in the tertiary care centers is actually required. Establishment of hereditary cancer clinics, as I said before, we have planned for hereditary gynae cancer clinics in our center, because then only we'll be able to provide. We are planning to train one of the nurses or somebody for that purpose and starting it off. Cross referrals of the related cancers, like we talked about colorectal included in this, and then the gynecology, GI surgery, endocrine surgery, because breast and ovarian, lot of, so that is required, because we treat our patient, don't evaluate, don't send them for testing for the other cancer, which maybe they might be sitting at risk for that. So that is required, that these are the clinical implications for all this knowledge. And then we should be able to then only provide the screening and risk reducing opportunities, and better survival and prognosis of the hereditary cancers is well known. So if we do all this, we'll be definitely benefiting a large group of patients. Thank you so much.
Just wanted to know whether these cards are commercially available. Yes, absolutely. And
That's why, you know, people who can afford should be benefited with that. So it is very much.
in Indian world, real world, what is the prevalence of Lynch syndrome which we see? Do we have any data?
Data, maybe I'll not be able to exactly give you, though I had some papers, I didn't include them there, but it's, yes. Currently I'm having a patient, and I was really looking for where to send her for the test. She has a very strong family history of suggestive of Lynch syndrome. So, yes, I mean, that's what. I think it is the second one, because, yeah.
In colonic cancer, it's much less than reported in whites. So, but still we get, like, I would say around 6 to 7% of those cases.
Because in the last,
it's not that high. It's not as barely have like
they have more.
40%.
Yeah, but hereditary breast ovarian BRCA1 and 2, there were papers from Indian literature, ma'am. They have higher actually. And for this also, I'll tell you, within last 2-3 years, I think this is the third patient that I have come across.
So after colonic is endometrium in the literature.
So that's what the need for
That's the purpose.
because they were
Yes.
presenting with one.
Yeah, because otherwise it just goes in their follow-up. Never comes to us for the screening.
So the adenoma malignum is now a nucleus cytogenetic carcinoma of a gastric type of adenocarcinoma of the cervix. So we had one case of that, and the patient has presented with a fluid trigger. But what was, I just a joke about that was that I told my resident कि पता करो इसको mucosal pigmentation है कि नहीं है. He came back with a photograph of the lips, nicely lipstick on them. So I'm like, he's like, I couldn't ask her to take the lipstick off, I said, जाओ उसको बोलो दोबारा भेजेंगे.
Simply what the brain knows, the eyes will see. So if we don't know about it, we'll never see.
But that's the gender issue I was talking about. Because as a male resident, I could tell her.
So thank you, ma'am, for any question.
So I will ask the question, how was she treated? How was she treated? Madam took the lecture. Because radiation. So many times we have vulval cancers after CS cervix treated with radiotherapy. We do see them. So that is one. But syndromic type, I don't know if endo. Yeah. True. In general, cervical doesn't have. It was only this adenoma malignum with this fused agar that we talked. So if the patient is there, best is to test that. Okay. So then obviously it will be that if there's a strong family history, then the concerned person will have to go for the testing. No, she can come to gynec oncologist, she can go to geneticist, counseling is required, and then test, and then the prophylactic and the screening will be with the gynec oncologist.
So thank you, ma'am, for very nice talk on various kind of the gynecological malignancy and their screening method. So, felicitate. जाना है तुम्हें? मैम को
Due to unavoidable circumstances, Dr. Nuzhat Hussain ma'am will be taking our leave now. I request Dr. Rajni Gupta ma'am to kindly honor her with the memento. Thank you for gracing the occasion, ma'am.
So in continuation, our next speaker is Dr. Preeti Agarwal. She is MBBS, MD, DNB Pathology from King George Medical University. Her area of interest is histopathology and cytopathology with special interest in tumor pathology and liquid waste cytology. She is honored during his MBBS tenure and have got the various award. Most is the prestigious award is the BC Roy Pathologist for 1 year award in 2022 by Indian Medical Association, Lucknow, UP, India. She is having the current project 8 and number of publication is 74. Her topic is application of FISH in solid tumors. Dr. Preeti, welcome.
Thank you, ma'am, for your kind introduction. Thank you, Dr. Neetu, for calling me for this talk. So, why fish in me? I am basic a morphologist. I call myself a morphologist. I am a morphologic pathologist, and it's a molecular technique or a cytogenetic technique which involves a microscope and involves seeing cells. So that's why fish interests me a lot. So what I'll be talking about, because you have a workshop on fish post lunch, so I'll be more concentrating about how you interpret fish, because doing a procedure is important and its interpretation and correct interpretation is equally important. So why do we do fish? We do fish because it is a technique which gives you interpretation on formalin fixed paraffin embedded tissue. So once we have seen the tumor under the microscope, identified the tumor cells, we can apply a genetic test and see whether few chromosomal translocations, amplifications or deletions are present in those cells or not. Secondly, it does give you three information. It can help you diagnostically, it can help you prognostically and predictively. So by an example, we have a dermatofibrosarcoma protuberans. It is a soft tissue neoplasm. You do fish for COL1A PDGFB. So if COL1A PDGFB is present in those tumor cells, it diagnoses that it is DFSP. It cannot be other tumor else from DFSP. Secondly, if it is present, it confers that it has an intermediate malignant potential. The tumor will be of intermediate malignancy. Third, if it is present, the tumor will be sensitive to platinum based therapy. So it has given you diagnostic information, a prognostic information and a predictive information. So three information provided by a single test when interpreted correctly, and the procedure is performed with absolute precision. So fish results are obtained by counting hybridization signals in probe for each cell. So what are the notable advantages offered by fish as a technique if with respect to other techniques like PCR and MLPA we have seen? So what are the advantages? First, it gives you control cells. If I am running a tissue section, I'll have few tumor cells, I'll have supportive stromal cells as well. So stromal cells, like suppose we are doing an fish for ALK. So normally each and every cell has an ALK in it, normal. If it is translocated and there is a break apart, then it is abnormal. So a tumor cell will have abnormal ALK expression and a normal supporting cells will have a normal ALK expression. So in this technique you can see a normal cell as well as tumor cell in the same section. Secondly, pseudo amplification can be differentiated from true amplification. Like if there is a polysomy of chromosome 17 where HER2/neu is located. So you will have multiple HER2/neu signals along with CEP17 signals as well. So this will be a polysomy. If you will have increase, अगर आपके पास बहुत सारा HER2 signals आ रहा है, so that means it is a true amplification. So true amplification can be differentiated from pseudo amplification on fish technique. Second, you can detect translocation and deletion both together. अगर मेरे पास break apart हो रहा है तो translocation है, या fusion हो रहा है तो translocation है. अगर एक signal ही हट गया है तो वो deletion है. तो आप दोनों चीजों को एक ही साथ एक जगह पर देख सकते हो. Secondly, मल्टीपल जीन पार्टनर्स भी हम कर सकते हैं. वी हैव मल्टीपल कलर्स, हमारे पास रेड है, ब्लू है, एक्वा है, तो वी हैव मल्टीपल कलर्स. तो हम एक ही जीन के कई सारे पार्टनर्स को भी टेस्ट कर सकते हैं. जैसे कि हमारे पास EWSR1 के साथ ET4 होता है, ET1 होता है, AML होता है, तो ERG होता है, तो 4 FLI1 है. तो हमारे पास इतने सारे उसके पार्टनर्स हैं जिसके साथ वो ट्रांसलोकेट करता है. हम सारे पार्टनर्स को एक साथ एक सेल पे भी विजुअलाइज कर सकते हैं विद दिस मेथड. Second, it is recommended by all the committees that fish should be interpreted by 2 independent observers which are not biased by their observation. आपको 2 इंडिपेंडेंट, सो आपके पास जो भी रिपोर्ट आती है वो कॉन्कॉर्डेंट रिजल्ट की होती है, एक मीन रिजल्ट की होती है, विच गिव्स यू बेटर आउटपुट. Secondly, it also gives you recognition of heterogeneity within the tumor cells. We all know that the tumor cells are heterogeneous population. Few cells will be showing amplification, few cells are not showing amplification. जैसे HER2 का है, तो हमने एक पेशेंट को, पहले हमारा HER2 आया था, हमने उसको ट्रांसक्रिप्शनल थेरेपी दी, पेशेंट ने आपको पेशेंट रिस्पॉन्ड किया. आफ्टर सम टाइम ही और शी स्टॉप्स रिस्पॉन्डिंग. अगर आप फिश करें तो आपको हो सकता है पता चले कि उसके there is a heterogeneous population. 10% of a clone is having HER2 amplification and there is some clone which is not having HER2 amplification. So that determination can be determined by this technique. So it is a very useful technique as compared as in solid tumors as such, where visualization gives you an added advantage. So I have told you कि हम nucleus देख सकते हैं. So this is the DAPI dye and we can see these tumor cells and we have the supporting cells as well. So tumor cells are large, irregular. We can see these tumor nuclei on the microscope. And this is the image which is showing a CEP17 probe for HER2/neu, where you can see that there are 2 CEP17 signals can be identified for HER2 in a HER2/neu probe. So what is the disadvantages? अब हर एक चीज़ का एडवांटेज है तो डिसएडवांटेज भी होगा. डिसएडवांटेज क्या है? लिमिटेड असेसमेंट होगा. आप एक ही स्लाइड के कुछ ही सेल्स को ही इंटरप्रेट करोगे और द डापी डाई आपको उतना अच्छा मॉर्फोलॉजी नहीं दिखाएगा जितना आपको HNE स्टेन दिखाई देगा. डिस्क्रिपेंसीज हो सकती है इंडिपेंडेंट ऑब्जर्वर में इन लिमिटेड. जैसे आपका अगर कोई केस है जिसमें लो लेवल एम्प्लीफिकेशन है या फिर इक्विवोकल केस है तो उसमें डिस्क्रिपेंसी हो सकती है. हम कहेंगे कि जी नहीं, मेरे हिसाब से रेशियो 1.9 है और किसी के हिसाब से रेशियो 2.1 है. तो रेशियो जब आपका 3, 4 या 2.5 एंड प्लस होता है तब प्रॉब्लम नहीं होती है. व्हेन द रेशियो इज बिटवीन द रेंज विच इज द कट ऑफ रेंज, उसके आसपास होता है, तब डिस्क्रिपेंसी और प्रॉब्लम होती है इसमें. सेकेंडली, इन फिश में हम ब्रेक अपार्ट सिग्नल और फ्यूजन सिग्नल की बात करते हैं. तो ब्रेक अपार्ट में देयर इज स्पेसिफिकेशन कि आपके पास जो सिग्नल डिस्टेंस है वो 2 सिग्नल डायमीटर के बड़ा होना चाहिए. तो किसी के लिए वो मेजरमेंट थोड़ा कम हो सकता है, किसी के लिए थोड़ा ज़्यादा हो सकता है. तो देयर इज अ स्मॉल पार्ट ऑफ सब्जेक्टिविटी विच अकर्स इन फिश. फॉर दिस देयर आर मल्टीपल सॉफ्टवेयर, जैसे कि ASI सॉफ्टवेयर है जो हमारे इंस्टीट्यूट में अवेलेबल है, विच वी अप्लाई फॉर इंटरप्रिटेशन ऑफ फिश. थर्ड इज प्री एनालिटिकल स्टेप. प्री एनालिटिकल स्टेप, एनालिटिकल स्टेप्स आप सब पढ़ो आज वर्कशॉप में और कल वर्कशॉप में देखोगे. द एनालिटिकल स्टेप्स कि आपको कैसे डीपैराफिनाइज करना है, हीट कैसे करना है, कैसे आपको एंजाइमेटिक डाइजेशन करना है, प्रोब डालना है, हाइब्रिडाइजेशन कैसा होगा. पर उससे पहले प्री एनालिटिकल स्टेप्स आर इक्वली इंपॉर्टेंट. पहला FFPE सेक्शन आप सिलेक्ट कौन सा कर रहे हो. आप जो सेक्शन सिलेक्ट कर रहे हो दैट शुड हैव एन एडिक्वेट अमाउंट ऑफ ट्यूमर. दैट सेक्शन शुड नॉट हैव अ लॉट ऑफ फाइब्रोसिस या फैट के जब आप सेक्शन को प्री ट्रीट कर रहे हो तो आपका सेक्शन फ्लोट कर जाए. सो यू शुड select the section properly. It should be properly fixed and processed. In any molecular technique you want to do on an FFPE section, even IHC as well, a protein detection technique, the section should be fixed and processed properly. अगर आप ओवर फिक्सेशन करते हैं तब भी लॉस ऑफ एंटीजेंस एंड एंटीबॉडीज एंड मॉलिकुलर टारगेट्स होता है. अगर आप अंडर फिक्स करते हैं तब भी होता है. सो द सेक्शन जब से आपने ट्यूमर टिश्यू निकाला है तब से उसकी क्वालिटी मेंटेन होनी चाहिए. अगर आप उसको एट द एंड PCR या फिश या फिर किसी भी साइटोजेनेटिक टेक्निक से टेस्ट करना चाहते हैं. सेक्शन की थिकनेस 2 to 4 माइक्रोन होनी चाहिए. अगर आप ओवर थिक सेक्शन ले लेते हैं, अंडर थिक सेक्शन ले लेते हैं, तब भी आपकी टेस्टिंग जो होती है वो इनवैलिड हो जाती है. सेकेंड, द परसेंटेज ऑफ ट्यूमर सेल्स. अगर आपने एक सेक्शन ले लिया जिसमें स्ट्रोमा बहुत ज़्यादा है, ट्यूमर सेल्स 8-10 हैं, तो आपको 100x माइक्रोस्कोप पे जब हम ऑयल पावर पे इसको इंटरप्रेट करते हैं तो लोकलाइजेशन ऑफ सेल्स बिकम्स डिफिकल्ट. सो आपको जो सेक्शन सेलेक्ट करना है, दैट इज इंपॉर्टेंट, दैट शुड हैव a good amount of tumor cells so that you can visualize them easily and interpret them easily. Solid tumors जिनमें fish technique recommended हैं, those are breast cancer, lung, glioma, soft tissue tumors namely Ewing sarcoma, synovial sarcoma, dermatofibrosarcoma protuberans, gastric and ovarian cancers. So result interpretation, अब हम उसकी बात करेंगे. तो रिजल्ट इंटरप्रिटेशन में आपको अपने काउंटिंग वेरिएबल्स पहले डिफाइन करने पड़ेंगे, SOPs पहले डिफाइन होने चाहिए, हम कितने सेल्स की काउंटिंग करेंगे ये भी डिफाइन होना चाहिए. आज हमारा मन आया हम 50 करेंगे, कल हम मन आया हम 100 करेंगे, दैट इज नॉट डन. यू शुड हैव अप्रोप्रिएट काउंटिंग एंड इंटरप्रिटेशन SOPs beforehand before you start your interpretation, and mostly these are provided by American College of Medical Genetics and Genomics along with ASCO-CAP guidelines, which takes care of the cancer genomics. Secondly, you should have the result with second diagnostician. What it ensures reproducibility, analytical reliability बढ़ जाती है और risk of errors भी आपके कम हो जाते हैं. फिर हमारे पास ऑटोमेटाइज्ड स्कोरिंग सिस्टम है, ASI अप्लाइड सेक्टोरल इमेजिंग इजराइल की सॉफ्टवेयर है विच वी यूज इन आवर डिपार्टमेंट. फिर आपके पास इंपॉर्टेंट टू नोट, प्लीज नोट दीज थिंग्स. फर्स्ट, आइडेंटिफाई द न्यूक्लियस बिफोर काउंटिंग द सिग्नल ऑन इट. आपके पास डापी में वेल डिफाइंड न्यूक्लियर आउटलाइन और न्यूक्लियस होना चाहिए जब आप उसकी सिग्नल काउंटिंग करोगे. कोई भी न्यूक्लियस जो आपको लगता है इट इज़ नॉन इंटरप्रेटेबल या फिर वो फजी बॉर्डर का है, आप उसको प्लीज़ अपनी काउंटिंग में मत इंक्लूड करिए. सेकेंड, अ सिग्नल विच इज़ प्रेजेंट ऑन द न्यूक्लियर आउटलाइन शुड नेवर बी काउंटेड. अगर आपका आउटलाइन के पर पड़ा है या उसके जरा सा भी बाहर अबट कर रहा है, उसको आप डिलीट कर दोगे, आप उसको काउंट नहीं करोगे. सिग्नल विच इज़ विदिन द लिमिट्स ऑफ द न्यूक्लियर आउटलाइन शुड बी इंक्लूडेड इन योर इंटरप्रिटेशन. सेकेंड, ड्यू टू कंडेंस्ड क्रोमैटिन कई सारे सिग्नल्स आसपास होते हैं, तो अगर एक सिग्नल डायमीटर से कम डिस्टेंस है 3-4 सिग्नल्स में, तो हम उनको एक सिग्नल मानते हैं. तो अगर आपके पास एक डायमीटर.
These are the malignancies where targeted therapy have been developed for such a long time. So we'll see by these two cases very briefly how these diagnostic modalities, cytogenetics, FISH and the molecular testing methods are helping diagnosing our patients and prognosticating them. So this is the first case, 53-year male from Lakhimpur who presented with dragging sensation in the left upper quadrant for 3 months, loss of appetite for 3 months and history of weight loss. There was no history of fever, jaundice or any bleeding manifestations, and there was no addiction or prior comorbidities. So on examination he had pallor, no icterus, edema or lymphadenopathy, but there was massive splenomegaly, spleen palpable up to umbilicus, almost 20 centimeter below costal margin. There was no hepatomegaly. So with this presentation we can see that the causes of massive splenomegaly may be multiple. There can be general causes and there can be hematological causes. So general causes are extrahepatic portal venous obstruction, portal thrombosis or fibrosis, tropical splenomegaly and kala jar. So we know that these are the common causes of massive splenomegaly. But coming to the hematological causes, it can be myeloproliferative neoplasm like CML and primary myelofibrosis. It can be lymphoproliferative disorders like CLL, PLL, prolymphocytic leukemia, hairy cell leukemia, marginal zone lymphomas and other lymphomas which are not that common but they can present with massive splenomegaly. So the first investigation in such cases is we have to look for complete blood count to see what is the hemoglobin total count and platelets. So we can see that there is anemia, hemoglobin is 7.1 and total count is 74,900. Platelets are normal. So there is marked leukocytosis, and if you see the differentials, mostly these are neutrophils, mature neutrophils, lymphocytes are 5%, myelocytes only 1%, and there are 1% blast in the peripheral smear. Other organ functions are normal, LDH is elevated, and so the features, if you take in the background the massive splenomegaly, high counts and then this type of differential, you think that probably this patient is having myeloproliferative neoplasm because there is a significant proliferation of myeloid series cells here. But mostly these are mature neutrophils. So further investigations were done, bone marrow aspiration and biopsy. We showed that it is a hypercellular marrow with megakaryocytes were normal, and myeloid erythroid ratio, which is normally 3:1, here it is 7:1. So there is marked myeloid proliferation. Granulocytic series cells are 84% and blast in bone marrow are 3%, so less than 5%. So again, these features are suggestive of MPN and probably chronic granulocytic leukemia or chronic neutrophilic leukemia, what we know as. So before saying that this is a chronic neutrophilic leukemia, we have to rule out other myeloproliferative neoplasms. So for that, we did the BCR able to rule out CML, that was negative, and other myeloproliferative reflex panel, which was the JAK2, CALR and MPL mutation, that also was negative. But then we took the NGS panel for other myeloproliferative neoplasm related molecular abnormalities, and there it was CSF3R positive, which is a sort of specific mutation which is associated with chronic neutrophilic leukemia. Along with that, we additionally got AXXL1, which was positive. Again, this is a mutation which is found in myeloid malignancies and having poor prognosis. So final diagnosis was chronic neutrophilic leukemia in this case. So chronic neutrophilic leukemia is basically a type of rare myeloproliferative neoplasm, which is not being defined as any other well-defined MPNs like CML and other myeloproliferative neoplasms. And here you can see that there is quite neutrophilic, myeloid proliferation with presence of mature neutrophils and peripheral blood, hypercellular marrow, but the blast percentage will be almost less than 1% in peripheral blood, less than 5% in bone marrow. So this is a rare neoplasm, and it is such rare that there is the true incidence is still not known how common it is. Median age of diagnosis is 66 years. There is slight male predominance, and the hallmark is sustained chronic mature neutrophilia. So why this is important? Because when we see patients with neutrophilia, we always think whether it is a reactive neutrophilia, which is also known as leukomoid reaction. So whether it is leukomoid reaction, whether it is atypical CML, whether it is chronic neutrophilic leukemia. So when you have such a differential diagnosis, the mutation which is specific for chronic neutrophilic leukemia definitely helps you in making the diagnosis of CNL. So these are the diagnostic criteria of chronic neutrophilic leukemia. You can see that there should be peripheral blood leukocytosis more than 25,000, out of which more than 80% should be mature WBCs, that is mature neutrophils, and myeloblasts should be rare, monocytes should not be increased, there should not be any dysplasia. And then if you see the molecular testing, and you have to rule out other MPNs, presence of CSF3R or other activating CSF3R mutations, this is also coming into the diagnostic criteria of this entity. If you do not have this mutation present, then you have to do much laborious work to rule out any other possibility before you say that this is chronic neutrophilic leukemia. So the presence of mutations and the techniques which are available nowadays definitely have made this diagnosis easy. Treatment options for these patients are hydroxyurea, that is cytoreduction in the form of cytoreduction, then interferon, JAK2 inhibitors, and demethylating agents like azacitidine. There are the case reports of using these medicines in these entities. But finally, the curative option is only stem cell transplant, allogenic stem cell transplant, because invariably these patients in long-term follow-up, they will transform into blast crisis or a form of acute leukemia, which is life-threatening. So this is about the prognosis. It's a poor prognosis in these patients. So differentiating it from CML is very important, because CML has very good prognosis nowadays, and these entities have poor prognosis. And this mutation, especially the T618I mutation, has relatively rapid progression, aggressive disease, and worse outcome. So again, you have a diagnostic use as well as a prognostic implication of this mutation when you get this. So our patient was started on hydroxyurea 500 milligram twice a day. There was some reduction in the total count, but anemia didn't improve. Then severe anemia persisted, which required transfusion. So he was shifted to Jakavi, which is ruxolitinib, a JAK2 inhibitor, again targeted therapy. But again, anemia and leukocytosis persisted, and then in the third line, he received azacitidine, 4 cycles, no response, and invariably this patient deteriorated, and this patient expired. So over a period of 1.5 years. So this again shows that this entity has a poor prognosis. Now we'll go to the second case. So this case is a case of chronic lymphocytic leukemia, again a very common hematological malignancy where we can see that what is the role of fish at the time of relapse. So basically in all hematological problems, whenever we are starting treatment, before that we try to get the cytogenetic and fish data or molecular data to prognosticate those cases. So basically these tests are done baseline. But there are some diseases where at the time of relapse, again doing the same molecular test or genetic test, fish, is very, very important, because over a time period when your patient gets treated with some modality, they acquire additional mutations, okay, and that can have again long-term implications and some therapeutic implications also. So that's why it is very important. So we'll see this case, again 79-year male, so almost 80-year-old male, no prior comorbidities, performance status is okay, of 2, diagnosed to have high counts on routine CBC investigation for tiredness. That was in June 2018. No fever, weight loss or bleeding manifestation, but there was significant tiredness. So he was almost sort of bed bound, not able to do the routine activities. Pallor was there, no lymphadenopathy and no organomegaly was there. So if you see the CBC hemoglobin was 9.7, mild anemia, very high counts, 39,800, and most of them, they were mature looking lymphocytes with some smudge cells. So we thought that with peripheral smear that this patient is having a chronic lymphoproliferative disorder, and most likely a diagnosis in such cases with such a peripheral smear finding is CLL, but we have to confirm it by flow cytometry. So this is a specific test to confirm the diagnosis of CLPDs, CD5 positive, CD23 positive, which is a hallmark of CLL. So that was positive, and there was CD20 weak positivity, CD200 positivity, and FMC7 was negative. So all the markers were suggestive, very much suggestive of chronic lymphocytic leukemia. So when we see how we should investigate these patients baseline when we diagnose a patient of CLL, along with the other history, CBC, marrow, aspiration, biopsy, and all, there are some additional tests which should be done. These are the genetic tests. So you can see that molecular cytogenetics. So fish for deletion 13q, deletion 11q, 17p, and addition of 12, trisomy 12 in peripheral blood lymphocytes should be done always, whether in general practice or even in clinical trial. So this should be done always. Along with that, there are some other mutations like TP53 mutation which should be done always, and immunoglobulin heavy chain variable region mutation assay should also be done always. So why it is important? Because we can see that deletion 17p, if it is there, which is present in almost 4 to 8% of patient baseline, if it is there, you can see that median overall survival is only in the range of 31 to 33 months. So almost 2 to 2.5 years survival, and there is early need of treatment and poor prognosis. Okay. Similarly, TP53 mutation, we can see that the overall survival is almost 21 to 90 months. So very poor survival in these patients. So knowing about these molecular abnormalities at baseline while you are planning treatment for your patients, and when these deletions or these mutations are present, they also give you some idea that what type of drug you have to use, because all drugs are not going to work in these cases. Okay, if you treat by conventional treatment, these patients are going to fail in the next 6 or 9 months, and they are going to relapse early. So in our patient, Coombs direct test was negative. This we do because patient has presented with anemia in CLL, so you have to rule out autoimmune causes for that. LDH is normal, chest X-ray is normal, viral markers are negative. And we did CLL fish panel because we are going to treat, because your patient has presented with anemia. So this is right 3 staging. Staging wise, this patient needs treatment. So we did the fish panel, and no abnormalities were detected at the baseline. Bone marrow was not done, cytogenetics was not done, usually not required until your patient has bio pancytopenia. And TP53 mutation and IGVH mutations are costly investigations, so that was also not done at the baseline in this patient. Probably a patient denied for that. So coming to the cytopenias, they are very common. So 25% of cases will develop present with autoimmune cytopenias, and recent data says that 5 to 10% will have autoimmune cytopenia like autoimmune anemia, which is the most common one. So that was not the case in our patient. So if you see the patients without 17p deletion, see the treatment protocols. So here the preferred regimes are ibrutinib, acalabrutinib or venetoclax based regimes. So this is the preferred one, but other recommended regime, because these drugs are very costly and most of them they are not available in India. So we have to look for other regimes. So bendamustine and rituximab based combination is very well preferred, but you should know that the patient should have a good performance status. Here we are dealing with a patient who is 80 years old, so probably he is not going to tolerate this chemotherapy very well. So we have other options like chlorambucil or rituximab, which can be used in these patients who are very frail elderly patients and not able to tolerate the chemotherapy very well. Again, this is a more schematic diagram to show that how you choose the first line treatment in CLL. So if your patient is not having 17p deletion and he is a go-go, means his performance status is very good, you can go for any type of chemotherapy, then FCR or ibrutinib may be used. But if you are slow go, means elderly patient, poor performance status, then you should go for more newer type of chemotherapies which have less side effects and all. But again, as I showed you, that rituximab is again chlorambucil and rituximab is also one of the options for such patients. So this patient was started on single agent rituximab 375 mg per meter square. He received six cycles of that every 28 days, and you can see that with the treatment of rituximab, the hemoglobin has gone up about 10, and then it was maintained about 10, even reached up to 14, and then it was almost always maintained about 10 till 2019 July. So after that, what happened? June 29 onwards, you can see that the counts were initially controlled, but now they started rising from 15,000 to 41,000, 41, and then 48,000. And there was associated anemia, again appearance of anemia and thrombocytopenia. So it is a definitive evidence that your patient has relapsed now. He had a good response for almost 1.5 years, and now he has got a relapse. So how you proceed here when your patient has relapsed? So again, there are guidelines how to manage relapsed chronic lymphocytic leukemia and applying guidelines to practice. So what are the investigations which should be done here? Again, at relapse, patient should be evaluated like the baseline. So like it's a new patient for you again, and you have to again investigate the patient the similar way you investigated at the baseline. So you do CBC, Coombs test, cytogenetics, and again bone marrow aspiration and biopsy. So here again we can see that counts are 55,000 and 10% pro lymphocytes are there. But Coombs direct indirect was negative, and fish panel for CLL was done, which showed that there is 17p deletion in 60% of cells in interphase fish. So this is additional acquired abnormality which was not there at the baseline. So what is the significance of this abnormality at this time point? So this is found in approximately 3 to 8% at the diagnosis, but it can rise up to 30% in the patients of CLL who have relapsed after the previous lines of treatment. So it is one of the most frequently acquired aberration triggered after treatment. So patients with 17p deletion have always been included into the highest risk prognostic category, showing the shortest overall survival and progression-free survival. So that is the information you get from these type of abnormalities which are available at the time of relapse. So now you can see that here, if the patient has got a 17p deletion, now your treatment algorithm entirely changes. So now you can not use bendamustine, rituximab, FCR, and all those chemotherapy regimes which are used for those who are 17p negative. Here the options are the newer drugs which are known as BTK inhibitors, Bruton tyrosine kinase inhibitors, which are acalabrutinib and ibrutinib, and then we have BCL2 inhibitor like venetoclax. So these are the newer drugs which have very good activity against 17p deletion, to such an extent that if you use these drugs in the management, the overall survival is almost similar whether your patient is 17p negative or 17p positive. So that is the importance of knowing these abnormalities, because we have lot of targeted or sort of precision medicines which can take care of that cytogenetic abnormality and make your patient survive longer and longer. So patient was started on ibrutinib 420 mg once a day, and patient had significant abdominal discomfort, nausea, anorexia. So we know that the newer drugs may come with newer significant side effect also. Although most of them they are safe, we should be knowing about all these side effects. So how I manage ibrutinib intolerance and complications. So we should be aware of the newer drugs, how to manage those complications with them. So this ibrutinib discontinuation rates have been up to 41 to 51% in some of the series. So what we did, we reduced the dose of ibrutinib to 280 milligram. So with that, patient is now tolerating well. So after that, he tolerated it well. And if you see the 2020 CBC reports of this patient, hemoglobin is more than 10, TLC is almost 12,000, platelet counts are normal. So he has responded very well to this modality. There are certain interaction of this drug, so that also we have to know. We should not use any antifungals along with this medication. We should not use any strong CYP3 inhibitors because that can increase the toxicity of this drug. So with that, I would like to thank. These are the two cases which I wanted to present, and probably these have shown that applicability of what we are seeing and reading from yesterday. Yeah, thank you.
मैम एक मिनट लगा दूँ लगा दो देख तब उसके बाद बुलाइए
So thank you, Dr. Shailen, for very nicely elaborating. Our next speaker is Dr. Swasti Sinha. Her talk is on cytogenetics in chronic myeloid leukemia, bridging the gap in current TKI era. Over to you, Dr. Swati.
Thank you so much, Dr. Rajni. I apologize. This was my third reintroduction because of the technical glitch, but that's all part and parcel of life. I wanted to, because since morning you guys have been listening to diseases, the new diseases which have all been made possible by the new ancillary techniques, run-of-the-mill, not run-of-the-mill routine testing. These are all specialized esoteric tests which are not available at a mass level. So how did that happen? So I decided to choose a topic which is chronic myeloid leukemia, which is a prototype cytogenetic abnormality. So chronic myeloid leukemia, it is a disease of many firsts. First of all, it's a blood cancer, it's a hematological malignancy, but in every tissue system now, there is a talk of this much cytogenetic and molecular based classification has taken over the routine diagnostics. But how did all start? It all started with chronic myeloid leukemia, and that's why I think that it earns its spot in today's lecture. Now, chronic myeloid leukemia, as I said, it's a disease of many firsts. It was the first disease which was diagnosed based on cytogenetics. Then it was the first disease where a targeted therapy was tried and became successful. Then this was the first disease when the scientific community moved over from targeted therapy towards precision medicine. Then CML was the first prototypic, the poster boy of precision medicine, where it all happened. So it presents, how did it all happen? It happened because it presents a unique model of oncogenesis. Now, and let's go back to the history, that as you can see in 1845, John Hughes Bennett and Virchow described the first case of CML. So they described the case with fever, infection, raised suppurative inflammation. Suppurative inflammation means a lot of pus, but they could not identify what disease it was. And then after then, it took almost 100 years and a quantum leap. Then when the discovery by Peter Nowell and David Hungerford of an abnormally small chromosome, the first consistent karyotypic abnormality associated with cancer. Now, Janet Rowley recognized that it has to do something with a chromosomal abnormality, and there is this minute chromosome which might be giving rise to this disease phenotype. In fact, the product of a reciprocal transformation between chromosome 9 and 22, then BCR-ABL, this oncogene was produced as a consequence of the chromosome rearrangement that characterizes CML. As you can see, the years passed by, and then the targeted therapy in 1993. So right from the first description of the disease in 1845, the target came in 1993, which was recognized as the best of the compounds at specifically targeting and killing CML cells. However, and then later on, it got clinical trials, it got FDA approval and was available for clinical use. Soon after that, the reports of so much time had lapsed in arriving at the cytogenetic basis of a disease, finding out what is causing it, finding out the target, how to stop that disease from manifesting, how to stop the severity of the disease, so much so, and finally when the FDA approval came, by that time so much imatinib had been used that the cases of imatinib, the primary imatinib TKI resistance had also come into light. By 2006, the second generation tyrosine kinase inhibitors of the family of drugs of which imatinib is a member. So the next line of drugs were made available. So as you can see here, so these two are the normal chromosomes. This large chromosome is this large chromosome 9, and the shorter truncated chromosome, which is the chromosome 22. So what happens in CML is that there is a reciprocal translocation. So part of the 9 goes and attaches to the 22nd chromosome, and the part of the 27th chromosome goes back and attaches to the 9th chromosome, which makes it a balanced reciprocal translocation. And the sites at which it happens, the fusion, the final oncoprotein which forms, it differs on the size based on the location at which this translocation has happened. So majorly the CML is P210 oncoprotein, P210, where exon 13 and 14 and A2 site on the ABL gene. Then this is the most common. More than 95% of CML cases have this CML P210. Now this P190 protein, it is less than 5%, less than 1% of CML, but more than 75 cases of acute lymphoblastic leukemia show this subtype. Then there is a P210 variant translocation and micro CML P230. So these are the relevant prevalence which is there in CML. Now the diagnosis of CML started with conventional cytogenetics. With conventional cytogenetics, the cells were arrested in metaphase, and then the translocation was demonstrated. And a standardized system of reporting was made, and that is how it was discovered that this particular patient harbors an abnormal chromosome giving rise to the disease. Now, so this is a cytogenetic diagnosis. Now, chromosomal abnormalities are detected by different cytogenetic techniques. It might be by conventional cytogenetics, or which is called the CBA, or the chromosome banding techniques, or by fish molecular cytogenetics. You have lectures for past 2 days on both the techniques. Now, standard karyotype analyzes metaphases of cells which is blocked in mitosis. And why this cytogenetics is relevant? Because apart from the main oncogenic chromosome, abnormal chromosome, if we see the karyotype, we can also find out if there is any additional chromosomal abnormality at the baseline. The number of metaphases observed must be greater to recognize primary and secondary abnormalities. Now, this Philadelphia chromosome, based on the city where it was discovered, this Philadelphia chromosome is found in all the cell lines of the blood and bone marrow. Except for the T lymphocytes, it's present in all the cells. Now, coming back to the molecular cytogenetics, now vis-a-vis the conventional cytogenetics and fish cytogenetics, as we had seen in the previous slide, there was variant translocation. So, where the conventional in a karyotype, it will not be demonstrated. So, where you just had a lecture on, a wonderful lecture on fish. So, by fish using the specific probe, once you know the target, see, we use cytogenetics when we don't know the target. We have to find out whether there is any structural or numerical abnormalities, and the whole karyotype is analyzed. But if the target is known, then we use specific probes to identify the variant translocations. After that, complementary fish for masked translocation in CML suspicion, where by fish, the regular fish, or by cytogenetics, the chromosome is present, but it is masked. So the break apart probe is used, so that the signal is broken apart rather than the regular fish. The break apart probe is used, and that is how it's used as complementary fish. Now, interface fish, where there is no need of blocking the cells in metaphase. So, there is no need of getting a high yield sample. A peripheral blood, a normal peripheral blood can also be useful. So, interface fish permits the evaluation of a large number of cells without the need for cell culture. So, this is the flow chart of CML diagnostics, conventional cytogenetics. Cytogenetics is preferably, conventional cytogenetics is preferably done on bone marrow. Fish cytogenetics can be done on peripheral blood for the reasons I told. So, 24 to 48 hours cultivation, because we want to arrest the cell cycle in metaphase. At least 20 metaphases is the minimal requirement. Then, if the karyotype is normal or insufficient, then normal karyotype without BCR-ABL translocation. Aberrant karyotype, where that chromosomal, that Philadelphia abnormal translocated chromosome is seen, plus minus any other variant structural variation. So, this variant complex and multi-way translocations of Philadelphia chromosome is also seen in around 6% of cases. So, BCR-ABL 922 translocation is seen in one chromosome because of two genes, gene BCR and gene ABL. However, there can be multi-way translocations as well. What is a multi-way translocation? When apart from the BCR-ABL gene, simultaneously other genes are also getting translocated. So, two-way translocation, three-way translocation. So, cases of CML have been diagnosed with as much as 5-way translocation. So, 5 genes cluster translocating. In that 5 gene member, one translocation is 922. So, the patient will have CML. But the other genetic material which is transferred in that simultaneous translocation will have its own manifestation. So, it will be affecting the response, it will be affecting how the targeted therapy, the intended targeted therapy is going to behave in that particular patients. So, this is the research interest area, this is the ongoing interest area as far as role of cytogenetics is CML is concerned. Apart from that, today CML has become a molecular diagnostic disease. This started as cytogenetics. Because of the availability of the sample and all, now CML is a molecular diagnostic disease. So, it can be diagnosed by qPCR, RT-PCR. Now, 3% of cases, despite all the cytogenetic techniques, 3% of translocations cannot be identified by routine cytogenetics, neither by molecular methods. So, this is the same complicated diagram. I don't know whether you will be able to understand. Just focus here that whole that larger, the bigger ABL gene the bigger ABL gene in the first diagram and the smaller BCR ABL gene, where part of this went and stuck over there and part of this went and stuck over there, and in the process an abnormal chromosome was made and a disease arrived. Now here, where is the target? So in the kinase domain, this kinase domain is in the Sark homology area of this gene, where the targeted, that imatinib, Gleevec was the first brand name, and imatinib targets this kinase domain region of the ABL. Now how does it help? What is the target? Now since the drug will attach in the SH1 region, now it will hamper the upstream translocation of this gene. Translocation will still happen. That abnormal Philadelphia chromosome will again be formed, but after formation of that abnormal chromosome, the mechanism by which the ATP uptake was happening and the oncoprotein was expressing, that process is stopped, but the abnormal chromosome will still be there. So imatinib based on this domain, these drugs were called tyrosine kinase inhibitors, because they go and attach in this kinase domain site and then they inhibit the ATP uptake, and that is how, even though you can see the abnormal chromosomes, but then the functional pathology will not be there. So these are the drugs with their chronology in the year wise. First line is imatinib, second line drugs, the new second generation nilotinib, bosutinib, ponatinib, in all chronological order based on the patient's fitness and comorbidities and the cytogenetic status and the molecular information. So CML, as I've said, it's a prototype cytogenetic malignancy. Now this slide, what does it show? That we saw the chronology. It took 100 years. Disease was diagnosed and then the targeted therapy. So earlier, before the arrival of the targeted therapy, there was the pharmacological management landscape was quite variable with not an assured success. And the final cure was when? The final cure for any hematological malignancy is the site, the factory should be stopped. So that assays which will be available on peripheral blood. Why do you want to do my bone marrow, which is an invasive procedure, at diagnosis? So in the disease chronology, for a few years, the role of bone marrow was taken out, because when earlier the qualitative PCR, the target moved from Philadelphia chromosome to identification of that oncoprotein, which was done by qualitative PCR also. So once the product was identified that yes, this product, BCR ABL product is there, so at baseline there was no role of how much product is there. So there was no role of quantitative PCR because of the costing wise. So qualitative, if you find that the disease producing oncoprotein translocation fusion protein is there, that was good to go, and by monitoring after, once the patient is put on targeted therapy, then the patient was successively monitored that the disease is, how the disease is responding. After that the guidelines were changed. Because more and more cases of scenarios appeared where the TK, everything was going right, but still many cases started behaving differently and were not responding in a way expected with a targeted therapy. That the target is there and we are hitting the target, still the response was not optimal. Having said that, more than 95% of cases responded well to imatinib. What about the 5%? So then the bone marrow came back with the recent guidelines. So a bone marrow test is required at the baseline for two reasons. We want to determine how much fibrosis is there once the disease is there, so that the fibrosis will affect the compliance of the patient, the cytopenias of the patient. They will determine whether the patient is going to have low counts, which will again secondly affect his or her ability to take the targeted therapy. Even though the targeted therapy is working well, if the patient is having bone marrow fibrosis, and account of the bone marrow fibrosis, the patient is having cytopenia as an unfit to have that targeted therapy, we might want to know that right before starting that targeted therapy, because all therapies will have their own cytopenias, drug-related cytopenias. So baseline bone marrows for two reasons: morphology for bone marrow fibrosis and cytogenetics, conventional cytogenetics. Why conventional cytogenetics? We are getting blood molecular signature is there for the same reason that approximately 5% of CML cases will have variant translocations, will have unknown complex cytogenetics, clonal chromosomal abnormalities, copy number variations, which will not be detected by molecular cytogenetics, which will not be detectable by PCR analysis. Then cytogenetics comes again for the monitoring, for follow-up. Once the TKI is instituted, that it finds a role again at 1 year. After a year, then every 3 to 6 months, you can follow the patient with molecular assay to find out how the fusion protein is decreasing, declining. Then at 1 year, that abnormal chromosome should disappear. So then we call it a complete cytogenetic response. The disease was when there was this abnormal chromosome was there, Philadelphia chromosome was there. By 1 year after therapy, ideally it should be in CCR. It should be in complete cytogenetic response. The abnormal chromosome should not be seen. If it is seen, then it will have another clinical implication. Then the targeted therapy will need to be changed from first line, second line, third line. The pharmacological management will change. The patient will also become, if the facilities are available, the patient can also be taken up for bone marrow transplant. So this is the relevance of cytogenetics. So this is again the guidelines of NCCN guidelines of CML. So these are the response category: complete hematological response, when all the cytopenias, when the counts have normalized, there is no immature cells, and there is no signs and symptoms of disease, with resolution of whatever symptomatic organomegalies he had. Cytogenetic response, I have told you, when the complete cytogenetic response, when there is no pH positive metastasis. Now for a minute, we will go back to this slide. Now this is the monitoring slide, that there is a number of leukemia cells in a given patient. Now this is the cytogenetic response. So, and the response is basically by molecular method. So molecular target, you call it MR1. When from the baseline disease, the disease is reduced to 10%. It goes on log reduction. So from any disease detected at baseline by quantitative PCR, now you just have to follow it with molecular quantitative PCR. In 3 months time, in 6 months time, if the disease is not decreased by 10%, then the disease by 10% in 3 to 6 months time. So this is MR1. So major response 1 by from 100% it is 10%. Then MR2 went from 10% at 6 months. So at 6 months our expectation will be that the patient on imatinib at 6 months should have 1 or less than 1 BCR radian translocation fusion protein. If the protein is above that, then you know that this patient is going into TKI resistance, that in future this patient will come back as the TKI which is being given to him is not working, or or the disease progression. Then at 12 months, this 6 months is a complete cytogenetic response, the disease should be 0. Now you see this level at 6 months, you see that there is a complete cytogenetic response. Philadelphia chromosome is not identifiable in a patient at 6 months. But still by molecular 1% oncoprotein, 1% fusion protein is still there. So that emphasizes that all these monitoring methods, cytogenetics, qualitative PCR, quantitative PCR, they are as good as the limit of detection. So the limit of detection is, that is why there is no complete response. There is no complete response. There is no complete molecular response, because now we know complete cytogenetic response started with 0%. Complete cytogenetic response when the abnormal Philadelphia chromosome was not seen. Now there is no complete molecular response, because with the available detection technologies, the lowest limit of detection, we can say that there is a major molecular response. When the disease has decreased to such a level that the disease will not manifest phenotypically. But we cannot be sure of, because the available technologies, we do not know whether the patient is cured or not. So going back to that slide where the bone marrow transplant was showing that matching survival, overall survival and PFS survival in pre-TKI era, in advanced phases of CML. So this major molecular response will tell that the disease will stop manifesting at any time. So now the concept. So we know now that even after the major, so the problem is to get the patient in MMR, and after once the MMR is achieved, to keep the patient in MMR. So once the patient has attained MMR, the patient, because we don't know, it is not a cure because the bone marrow has not been transplanted. The pathology is still there. The translocation is still happening. The translocation is still happening. What the drug is doing, the drug is just, the translocation abnormality is still there. The drug is stopping the expression, the phenotypic expression and the pathogenesis of that abnormal chromosome. So we really do not know what is the window of that clinical remission. So that is why now the concept of this TKI resistance and treatment-free remission, because when the patient will ask you that when my molecular test is less than 1, is less than 0.01, am I cured? Then this is a difficult question to answer, because for the reasons that with the current detection technology, with the current available techniques that we have, the patient in major molecular response, in a persistent stable major molecular response, can be said that it can be operationally cured or functionally cured, but we never know when the disease will come back again, when the disease will overpass the targeted therapy. So that is why now there is a talk, the recent update is that now we are talking about a treatment-free remission, which is the target for the targeted therapies. So why do you give targeted therapy? We are giving targeted therapy not to cure the CML. We have to achieve a time in a patient's life when he wants to say treatment-free remission, that the treatment that has been given to him, if we stop for how much time, if I stop, then the disease will not come back again. So during that time, if the patient is off treatment, but the patient is still in remission, that means the target is, the therapy is not given, that ATP access is not blocked, the patient is not on any tyrosine kinase inhibitor, but still the remission is there. So for treatment-free remission, we need a durable molecular response. What is a durable molecular response? From major, now the targets are also changing. So earlier cytogenetic response was there, then molecular techniques came and molecular responses came, then minor molecular response, incomplete molecular response, major molecular response. Now there is a concept of durable molecular response. So how do we determine what is a durable molecular response? So when the patient up more than that, so this was MR1, MR2, this is 10% log reduction, 10%, 1%, 0.1%, then 0.01%. So MR 4.5. So MR4 will be 0.1 when the disease is present in the body but at less than 0.01%. Then for a period of time on successive monitoring at this interval, then you can say that the patient is in a molecular remission and the remission is durable. How durable? Because the disease is persistently not detectable by all the available technology. So the trials, the IRIS trials which studied the role of imatinib, so then the patients on TKI were followed up for 8 years, and then it was demonstrated that imatinib itself had induced a complete cytogenetic response in 87% of the patients and long-term overall survival of 85%. That is as good as age-matched normal healthy subjects. So a patient has CML and a healthy subject can expect to have a normal life, a disease-free life with this targeted therapy. Now, 17% of the patients did not achieve a cytogenetic response, which was a primary resistance, because at that level of time, 6 months, there was no cytogenetic response. If there is no cytogenetic response, that means bone marrow at diagnosis, bone marrow at 6 months to find out whether the cytogenetic response is there or not. If there is no cytogenetic response, why to wait for the patient to go into a molecular, to lose its molecular response? Then the idea is to change the TKI, to upgrade, escalate the TKI there and then. At the first site, at the outset of the, when the failure to achieve a cytogenetic response, the indication to take up the patient for escalated TKI or to take up the patient for bone marrow transplant. Now, overall, imatinib did not obtain optimal results in 40% of the patients. So, this was the first prototype targeted therapy. After that, its successors had come and with the specific area. So, that is why this rate has come down. Now, during the imatinib treatment, the monitoring of clonal evolution proved to be very important. Now, the CML is now a molecularly diagnosed and molecularly managed disease. Cytogenetics, role of cytogenetics has decreased as far as CML is concerned. But looking at the event, just wanted to, because once the molecular potential is explored, the molecular targets have been identified, the concept of durable treatment-free remission have been exercised. Now the current talk is again, even few patients again are not able to. Now who will choose which patient is going in durable molecular response and which patients? Because not everyone. So with all this rigmarole, only 15 to 25% patients are there which can maintain a durable molecular response. So need to go back again to cytogenetics. Need to find out, is there any clonal evolution? Is there any clonal chromosomal evolution in Philadelphia? And now there are two issues to consider. After institution of TKI therapy, the Philadelphia chromosome is negative. So Philadelphia chromosome positive, and the residual Philadelphia negative chromosome which had escaped the TKI therapy, that might also develop clonal evolution and give rise to this resistance to TKI therapy. Now, achievement of complete cytogenetic response within the first 12 months of treatment is associated with long-term optimal response. So, if you see that the patient achieved its response 10% at 3 months, 1% at 6 months, and the patient is still in cytogenetic response at 1 month, then you can be assured that this patient might be a potential candidate for considering a treatment-free remission when the time point comes. So these have a predictive prognostic value. Now 10 to 12% of CML patients exhibit additional chromosomal aberrations in chronic phase. So these aberrations would have been missed if we will stop performing cytogenetics at baseline. When the disease progresses in advanced stages, when the disease progresses to blast crisis, even then there is a significant proportion of cases, almost 86% of cases in advanced phases of disease which have cytogenetic abnormalities. Now these chromosome changes, what is happening apart from the multi-way translocation, you keep the oncogenic protein or fusion protein separate. That Philadelphia chromosome is separate. Apart from that, the chromosome changes are clearly non-random, and there are two pathways of cytogenetic evolution. Major root changes, trisomy 8, trisomy 19, and there is an extra Philadelphia chromosome. And the minor root changes are when there are numerical abnormalities and one structural abnormalities. Now at least one of these changes is found in 15% on all CML cases. So abandoning cytogenetics in CML will be missing out these 15% patients. So altogether the 4 major root aberrations and the 6 minor root changes are present as part of the clonal evolution in 86% of the CML with cytogenetic abnormalities in addition to the Philadelphia chromosome. So though the disease has a target oncoprotein, but the disease response is not limited to that target oncoprotein. And this opens up a new question, this opens up a research area gap, that whether and leaves ample scope for precision medicine, moving away one step ahead from targeted therapy, whether apart in addition to the targeted therapy, is there anything else which we might need to do based on the chromosomal makeup of that particular patient, which will be available on cytogenetics. So these are the major cytogenetic events, additional chromosomal abnormalities. You are not going to remember all of these, but the only thing why this slide, that this is the Philadelphia positive, this is the clonal compartment of a CML patient where the Philadelphia clone is there, pH positive cells. Now the disease was diagnosed based on this pH positive cells. Targeted therapy were given for these pH positive cells. Now what about the pH negative cells? So there would, in two scenarios, in one scenario there is a escape of this Philadelphia. The Philadelphia positive cells, the Philadelphia positive clone responded to the TKI inhibitors. The Philadelphia negative escaped the TKI inhibitors, and then they evolved clonally. This is one. And the second thing is that TKI is also known to induce Philadelphia negative clonal chromosomal abnormalities. Persistent use of TKI, because the patient, as I have said, that the lifelong patient come and will ask how long will I have to eat my medicine. So this is a lifelong, because as we said that the abnormal chromosome is there, you just cannot take it out. You can stop its expression, its oncoprotein expression, that ATP is blocked, but the chromosome cannot be taken out of the body unless the additional further technologies, which is the area of interest these days with modified technologies. Otherwise CML patients will have to be, unless they are bone marrow transplanted, they will have to be on lifelong, majority of the CML cases will have to have a lifelong TKI inhibitor therapy, barring those patients which had followed those response milestones and had shown every indication and they are in persistent durable molecular remission. That small fraction of patient, 10% to 15% patients, can be followed up, whether in future they can be considered for a treatment-free remission, whether in those cases imatinib or the tyrosine kinase inhibitor therapy can be stopped or not. So pH pattern, we saw the pH negative and the pH positive chromosomal abnormalities, and they have a different pattern and they have a different disease connotation. So out of that busy slide, few specific abnormalities were indicative of a bad prognosis. Few abnormalities when present along with Philadelphia chromosome indicated that is a good sign. So not all clonal chromosomal abnormalities in addition to Philadelphia are bad. Few abnormalities, if they are present along with Philadelphia, they will just be an indicator that this patient is going to have a stable clinical course. So how do we decide that? We decide that by looking at the data, looking at the studies, that emergence of high risk additional chromosomal abnormalities in Philadelphia clone predict a poorer response to TKI and a higher risk of progression. So these are the high risk additional chromosomal abnormalities, and they create environment of genomic instability, especially in advanced phase. Advanced phase CML, owing to the disease itself, plus the factor of multiple TKIs have been tried in an advanced stage. To reach a patient, to reach that advanced phase, multiple lines of therapy must have taken, and that also had contributed to the genomic imbalance and giving rise to additional chromosomal abnormalities. So this was a regular article based on these additional chromosomal. I am highlighting the role of cytogenetics because now when we talk of treatment-free remission, then we have to stratify your patients all over again. We have to look at baseline, we have to follow those targets if the targets are there, and we have to risk stratify your patient to be able to tell them whether they can be in future, they can be potential candidate for treatment-free remission or not. Whether they can progress to this advanced phase disease. CML is a triphasic disease. Whether the CML can progress to acute leukemia as well. Blast crisis is acute leukemia, so blast crisis as well. So this whole revisiting the risk stratification is all being made possible by revisiting the role of cytogenetics in CML. So cases with are stratified based on the numbers of ACAs at the time of diagnosis, and then you have to follow with cytogenetics. Not as frequently as with molecular techniques, but at longer intervals. So they can also, as I said, they can predict stable disease phenotype or progression to other clonal hematological malignancies depending upon those specific additional chromosomal abnormalities, which a hematologist will know. Patients with progression, they will like trisomy, monosomy 8. So if a patient has a Philadelphia chromosome and shows monosomy 7, then we know this information is there at the baseline there itself. Then this patient will be potentially more cytopenic. This patient is at more risk of developing a blast phase, disease progression, drug resistance and all that. So this information we could get right at the baseline. Deletion of chromosome 9 derivation is associated to patients' bad survival. Trisomy 8 is associated with underlying germline predisposition. So WHO classification, the recent WHO classification has also included a new category of hematological malignancies with germline predisposition. So in CML, looking at those additional clonal cytogenetic abnormalities, few of the abnormalities have a germline predisposition, making them more prone to other germline tumors as a CML syndrome. Now in pediatric cases, the disease biology and this discussion holds well, except for the fact that the additional chromosomal abnormalities set the landscape, the cytogenetic landscape is different, and the response to TKI is also different. They have a diverse cytogenetic profile compared to adults with blast phase CML, and they have a distinct landscape. In pediatric, trisomy 8 and monosomy 7, they are the well characterized additional chromosomal abnormalities. If a child has a trisomy 8 along with Philadelphia chromosome, that indicates a stable disease in that child. And if monosomy 7 is a bad prognostic sign. So those are the cases which need looking out for through their years once they grow up to be adolescent and become adults. So younger age blast phase compared to the total CML. So these clonal abnormalities, the discussion that we have had so far, baseline additional abnormalities, and during treatment on TKI when the clone has evolved and giving rise to additional chromosomal abnormalities holds good for pediatric patients as well. So in this busy slide, the only point I wanted you all to see that this at the clonal evolution, this cytogenetic, this karyotype, if you can see the red ones and the green ones. So this was at the diagnosis. This karyotype is the diagnostic karyotype with these red on the left side. These were the additional chromosomal abnormalities at diagnosis. And the patient was put on targeted therapy. This is the monitoring karyotype. And at this time, if you can see all the green ones, they have reappeared from where? So they have clonally evolved. So this is a baseline and this is a follow-up cytogenetics showing so many additional clonal cytogenetic abnormalities bearing a bad prognostic impact. So in the end, careful cytogenetic analysis, what is the take-home message? Careful cytogenetic analysis retains its spot in CML management. Based on type, we want to know the type, frequency, timing of emergence of additional chromosomal abnormalities and phase of the disease, because they have a prognostic predictive marker when the disease is going to progress. In cases with insufficient molecular response, again there is a role of cytogenetics, ABL1 mutations should be considered. Then relationship between ACAs and the initial clinical scoring system would be of interest, and deeper analysis then all that list with every karyotype a new chromosomal abnormality will throw up, and then the studies then the patient will need following up to see how that chromosomal abnormality is attributing to the patient's complete makeup, the complete CML management, and that is precision medicine. So what are the future approaches in CML? So future approaches will be refinement of current treatment-free remission based on this information, which would be available through cytogenetics, precision medicine, and CRISPR. CRISPR is that palindromic repeats. And why this talk of CRISPR? Because of the cases that we saw that despite all that, despite talking of bone marrow transplant, despite talking about durable molecular response, the end line remains the same, that the patient would have to be on therapy lifelong. So to avoid that, because we know that the current TKI is not addressing the it is not addressing the abnormality is still there. So why not? So this is an attempt, since the oncogene stays intact, lifelong oral medication would be essential, even though this triggers adverse effects. So TKI adverse effects, cytopenias, and multiple systemic adverse effects will be there. So to improve upon that, leukemic stem cells remain quiescent. So in those cases, new therapeutic alternatives are still needed. Interruptions, deletions of the, so CRISPR technology is a clustered, regularly interspaced, short palindromic repeats. So the palindromic repeats which can be read either way. So they will be the same. So those sequences, if by that CRISPR technology, if by those repeats can be introduced in that sequence, where the two abnormal chromosomes were translocating, then the abnormal chromosome will not formed. Then the Philadelphia chromosome will not formed. In that cases, then the future is that if we detect, now the role of CRISPR is being investigated in CML. So if the target, the next target is, if the, in future, if we could target that the translocation, the abnormal chromosome is not there, then that would be a possible cure for these cases. So as I said, precision medicine is the is in a nutshell, is a mix of everything which we said: disease stage, social risk score, and role of NGS assessment. Because apart from cytogenetics will tell about additional chromosomal abnormalities, apart from that there are many somatic mutations also, epigenetics also, which will be giving rise to the response of a particular patient to the TKI. So with all this comprehensive genetic information for an individual patient, we might get that information to precisely target the pathology, the oncoprotein in a given patient. So this is called integrative genomic analysis, which takes care of everything. It looks at the chromosomes, it looks at the somatic mutations, it looks at the molecular targets, it looks at the sequences. So everything, and this is an integrative genomic analysis through which it's a pathway through which precision medicine can be is being investigated in CML. Thank you so much.
Thank you, ma'am. That was indeed a splendid talk. I am sure the audience will agree with me that every element of this session shared priceless pearls of knowledge with us today. I would like to extend my heartfelt gratitude to our chief guest for the day, Mrs. Rekha S. Chauhan, ma'am, for gracing the occasion. I would also like to express my heartfelt gratitude to our honorable chairpersons for the day, Dr. Rajni Gupta, ma'am, and Dr. Rashmi Kushwaha, ma'am, for sparing their precious time to grace the occasion. We are indebted to our honorable speakers, Dr. Kaushik Mandal sir, Dr. Nuzhat Hussain ma'am, Dr. Nisha Singh ma'am, Dr. Swasti Sinha ma'am, Dr. Preeti Agarwal ma'am, and Dr. S.P. Verma sir. We are indeed fortunate to witness your sessions, sir and ma'am. We are also thankful to our participants, attendees, and audience for their enthusiasm. Some memories become unforgettable treasures, remaining ever vivid and heartwarming. We hope and wish that this session and workshop becomes one such memory in your lives. We thus present our delegates with mementos as tokens of our gratitude and reverence. I would now like to request Dr. Inusha Panigrihi ma'am to kindly do the honors. Ma'am, please. Our honorable chairperson for the day, Dr. Rajni Gupta ma'am. Thank you for gracing the occasion, ma'am. our respected chairperson, Dr. Rashmi Kushwaha ma'am. We are privileged to have you, ma'am. Dr. Geetika Nanda ma'am from the Department of Surgery, KGMU. Thank you for gracing the occasion, ma'am. Thank you, ma'am. I now request Dr. Rashmi Kushwaha ma'am to kindly do the honors. Dr. Nisha Singh ma'am as our honorable speaker for the day. Thank you for gracing the occasion, ma'am. Dr. S.P. Verma sir as our honorable speaker. We are privileged to have you, sir. Thank you, ma'am. I now request Dr. Rajni Gupta ma'am to kindly do the honors. Dr. Preeti Agarwal ma'am as our respected speaker for the day. Thank you for sparing your precious time, ma'am. Dr. Swasti Sinha ma'am as our honorable speaker for the day. Despite the technical issues, your session was indeed very interesting, ma'am. Thank you, ma'am. The poster presentation competition that took place yesterday saw enthusiastic participation from across the country. The presentation was indeed very interesting. Hold your breath, dear participants, because here we have the results. I would now like to request Dr. Frani Sheth ma'am and Dr. Inusha Panigrahi ma'am to kindly do the honors. Ma'am, please. In the first place, we have Tripti Verma. Heartiest congratulations. The second place has been jointly acquired by Dr. Ayushi Jain and Dr. Gayatri Badarke. I apologize, Dr. Gayatri Badarke. Congratulations, ma'am. In the third place, we have Dr. Sidra Parvez. Congratulations, ma'am. Thank you, ma'am. Heartiest congratulations to all the winners and the participants. We would now like to honor the organizing team for their hard work in putting together this international conference at such a magnitude. I request Dr. Frani Sheth ma'am to kindly do the honors. Ma'am, please. Dr. Neetu Nigam ma'am, as our organizing secretary, has been our constant source of support and guidance in putting together this event. We shall remain ever indebted, ma'am. Ms. Surbhi Gupta as the organizing team member. Ms. Neha Rawat as the organizing team member. Ms. Kirti Upadhyay as the organizing team member. Ms. Shalini Chauhan as the organizing team member. And Mr. Praveen Kumar as the organizing team member. And of course, a very talented anchor for this conference, Ms. Shreya Palit. A big round of applause for her for a wonderful commentary. Thank you, Dr. Frani, ma'am. Last but not the least, I would like to acknowledge the untiring efforts of Mr. Rajneesh from Samrat Enterprises in putting together this event. I request Dr. Neetu Nigam ma'am to kindly do the honors and acknowledge the efforts of our organizers. Thank you, ma'am. With this, we come to the culmination of today's session. I request the participants to kindly collect their certificates while leaving the hall. We request you to join us at the Cytogenetics Lab, Center for Advanced Research, post-lunch for the workshop. Following the succession of events today, the workshop will continue for the next 3 days till 11th of February 2023 at the Center for Advanced Research, King George's Medical University. We expect your wholehearted participation from the participants and attendees in the upcoming days as well. I now request our delegates, attendees, and participants to kindly proceed to room number 106 on the ground floor for lunch. With that, I shall take your leave as the anchor for the event. Thank you.